कर लिया है फोन उनको सर, गुरदोष चौधरी को कर दिया है and he'll join in 5 minutes.
Okay, welcome Hitinder.
Morning sir. Morning.
Hello Hitinder sir.
Good evening. Good evening sir. Good evening.
Slides share कर ले थोड़ा.
Yes.
राखी मैम प्लीज थोड़ा सा राखी मैम प्लीज टिल्ट कीजिए थोड़ा सा और स्क्रीन.
हाँ.
Yes, now better.
सर आप स्क्रीन शेयर करके देख लीजिए 2 मिनट.
देख लो.
Yes sir.
दिख रहा है?
Yeah.
Yes sir. Sir, slide show. Yeah.
Okay.
Done. Good sir.
Very good.
Sir.
Don't disturb. Close that door. See, my grandsons are there with me, no, with drums, music, and everything. They just don't listen to me.
Those days, students never listened to you, sir. Now your grandchildren don't listen to you.
But that's a pleasure. That's a fantastic pleasure. I enjoy that more than anything else.
Good evening, Acharya sir.
Good evening. कैसे हो?
Sir, बढ़िया.
गौरव. नहीं गौरव नहीं ये. जितेंद्र.
Yeah.
कट करके स्मार्ट हो गए हो.
Thank you.
Sir, going by that experience of COVID, so I think we can no longer say that it's a bystander hepatitis in COVID these days.
No, it is causing some of the patients problem of you see splanchnic thrombosis, splanchnic system thrombosis, liver damage, and ACE are maximum expressed in actually cholangiocytes. You know that.
Dr. Gaurav is also
more than the lungs.
Okay.
And the intestines. That's what the finding says. So we don't know about the virus, right? And I was reading a lecture by the M.I.C.E, the CEO of the M.I.C.E. He says, I don't understand the virus. I don't understand how these people are developing vaccine. We took 15 years to develop a chickenpox vaccine. 18 years to develop a rotavirus vaccine, right? And how this, we are producer of largest amount of vaccine, M.I.C.E. And I don't understand yet how they are producing virus and billions of people are waiting. And what will happen to these responses or protection?
Now, more than that, adverse events following the vaccination, we don't have a window of follow-up. It's very short duration.
In the data, AstraZeneca or the Pfizer data, the protection levels are in 30s. Both control and test arms are 30s, 40s, not in hundreds. Based on that, they're jumping around.
Dr. Kaushal?
Yeah.
Okay, we are live now. So we can continue because we still have 1.5 minutes. So just kept it alive for a minute before.
But Kausal Hall A, who is doing? You have to be there both places, no?
No, sir, Surakshit will join us. So I've just talked to him. If I have to leave for Hall A a little early, then he'll be delivering the vote of thanks.
Right, right.
And
programs are there, no?
Suppose your discussion is extending for 5-10 minutes more, that is possible since Hall B will be empty. So
that is good. That is good.
But
Raki, you can talk.
Yeah.
Don't worry about time.
But please don't continue it for a very long time because people will not leave you and go to Hall A then.
Okay.
Hall A, already the speakers are in.
Okay.
Okay.
So
we are good. We are good to go. I think it is exactly 5:10.
Okay,
so Dr. Kaushal, over to you.
Good evening, everyone, and welcome once again to this day 3, which is the final day of our virtual annual INASL this year in 2020. And before we proceed further, I would like to make an announcement for all the delegates who've logged in today and for last 2 days also. They can have their e-certificates downloaded from the exhibition hall area from the platform. So they'll have to go to the exhibition hall there'll be a button for e-certificate downloading. They can click on that button and they will have a certificate by their name downloaded on their computer. So those who are interested in getting that certificate can go there and collect it. So we are starting our day with a satellite symposium, which is on how to deal with the complications of cirrhosis. And for that, I would like to invite our chairpersons, who are Dr. V.G. Mohan Prasad, who is the chairman and chief of gastroenterology at the VGM Gastro Center, which I've been told is the first NABH approved gastro solo center in the country. He's also the president-elect of ISG, and those of who don't know this, he's also the inventor of Hemospray. So welcome, Dr. Mohan Prasad.
Sir, one small correction. I'm a past president of ISG.
Oh, he was also
2013-14. It's long back.
Sorry about that.
Okay.
So we also have Dr. Abhijit Chaudhary, who is the senior director and head of department of HPB and liver transplant surgery at BLK Super Specialty Hospital, New Delhi. Dr. Gaurav Pandey, who is the associate professor of gastroenterology at SGPGI Lucknow, and Dr. Hitendra Garg, who's a senior consultant gastroenterology and hepatology at Indraprastha Apollo Hospital, New Delhi. So welcome all the chairpersons. So over to you to start the proceedings. Dr. Mohan Prasad, please.
Thank you so much for the nice words, and it's a great honor and pleasure. I thank INASL and Mylan for inviting me to chair this symposium, and my greetings to my colleagues, Dr. Garg and Gaurav, and thanks Kaushal sir for that nice word of introduction. We are straight away moving to a beautiful talk today because all three topics are not related, however related to the liver. So the first one is on AKI in end-stage liver disease, final nail of act fast. So when do you have to act fast? So is it HRS 1 or 2, or where we can go in slow in 2? And here is it, what is the cause of this acute kidney injury? And how fast have we to act to save the kidney? To deliver the stock, we have a brilliant hepatologist, Dr. Raki Maiwal, who's going to deliver the stock. So over to Rocky, and all the very best.
Thank you. Thank you, sir. And thank you, Dr. Kaushal and INASL, for inviting me for this talk. So are my slides visible?
Yeah, you can put it on full screen mode. Yes, fine.
So I'll be talking about AKI in end-stage liver disease. And the two things which have been put up is whether it's a final nail or we should act fast. And I would say it is both. So why is it the final nail? Because if we see the natural history of cirrhosis, AKI is not an early, but a very, very late complication. And a patient gets predisposed to develop AKI only after the onset of ascites. And the episodes of AKI and the renal dysfunction usually worsen with time progresses as the patient develops from a diuretic responsive to a diuretic refractory ascites and starts to develop a chronic form of renal dysfunction, gets repeated AKI episodes and HRS1. Now, we know about the MEL score, and to this audience, I do not need to tell, but we also know that this is the only score that is being used for allocation of organs for liver transplant, and it can be used and it performs very well for prognostication, even in patients with liver disease, with infections, variceal bleed, even in patients with alcoholic hepatitis, patients with HCC. And if you see the components and the equation of the MELD, we see that serum creatinine, which is actually a reflection of the renal system, has a weightage of around 9.57 points, which is only next to INR of 11.2. And we also know that the mortality of HRS AKI is almost 50% within 2 weeks, and 80% of these patients will die within 3 months in the absence of reversal with the vasoconstrictor. So therefore, a very, very ominous complication. And we also know that now that we have the ACLF and the canonic study clearly uses kidney dysfunction as the core criteria for defining ACLF, which also have a very high mortality in patients with decompensated cirrhosis. Therefore, it gives us a reason that we should be acting very fast to salvage and prevent AKI and and prevent and this ominous complication. And this is an important abstract and this year, which was published in ACLD by Sumit Asrani, where they showed that for the same MEL score, if you see, and what they did here was they took a large cohort of patients and they took MELD of around 25 and above, and they found that patients with a MELD score, when they stratified with the same MELD of creatinine, had a lower mortality as compared to patients who had MELD of 25. And this was when they compared these sets of patients, it showed that creatinine again was fallacious in patients with females. For the same MELD, the females had a higher mortality. This tells us that we can make a difference with the renal function. So we cannot change the bilirubin and INR because there's very little to offer there, but creatinine, if we can make a change here, we can obviously make a change in the MELD and the overall prognosis of these patients, and therefore it gives us a reason to act fast. Then how do we act fast here? So it is important for us to diagnose this complication early on, identify and correctly diagnose the spectrum so that we choose the therapy appropriately and rightly at the right time point. And again, it's very, very important that we should be assessing the severity and the response to these therapies very dynamically. And at the end of it, we have to prevent these future episodes and development of chronic kidney disease. So to diagnose AKI early, the revised definition, and we know that over the years, the definition of HRS has been evolving to tell us, because we are missing a lot of AKI, and that's how over the years, with each definition, there is a reason that we have to be not going by serum creatinine criteria, initially 2.5, then it was made 1.5, then the creatinine was excluded, then came the AKI, and now they have included the urine output criteria. So all this is happening because you have to diagnose it early on so that you can intervene early and make a difference. And we know that there are a lot of pitfalls of serum creatinine. It is influenced by a lot of factors here, which affect its production, measurement, and excretion. We know about the sarcopenia, muscle mass, which will influence, and the high jaundiced patients, the anasarca, the age and gender, as we already saw in this paper also, that the creatinine is fallacious and cannot be relied upon. Now, what about oliguria? Oliguria has not been evaluated apart from the intensive care unit setting, because here you need to catheterize your patient. And in this large study, they showed that in the intensive care unit, obviously creatinine performs much less inferior. It misses a large proportion of patients with AKI as compared to when we stratify these patients with the help of urine output criteria. This is our own data. And we again showed here that in the intensive care unit population, and we evaluated 291 patients with liver disease, the changes in urine output were actually preceding the changes in serum creatinine, and therefore urine output in this prospective study, we showed that is an important measure of renal functions in these patients. Now, coming to the next part, diagnosing the AKI correctly. So once we've diagnosed and made a diagnosis, it is important that we know whether it is due to infection, it is due to hypovolemia, it is due to hepatorenal syndrome, because the spectrum determines the outcome of these patients. And we see the worst outcomes, and these are two large landmark studies done initially in 2011. This was the AKI criteria using the 1.5 value of serum creatinine, and then came this study which used the revised criteria of AKI. So both these studies had clearly shown that the spectrum influences the outcome, and HRS patients have the worst outcome. Now, to be very simple with respect to the spectrum, we can say that the spectrum can either be functional or structural, and functional component will have volume responsive component and a volume non-responsive component. Volume responsive has a very good outcome with the routine therapeutic treatment, while it is a little difficult to treat these patients with HRS AKI. And amongst these structural causes, again, there is evolving data to suggest that even HRS patients can have some structural component due to injury by the damage associated and pathogen associated molecular patterns. The same patients may have shock, they may have some ischemia, they have drug related injury, toxicity due to bilirubin or bile acids, as we see in patients with ACLF. So there's definitely some structural component, and these, again, functional and structural etiologies, there may be a lot of gray areas where we could see patients with both the components. Now, how do we identify spectrum? It's very easy for us to do a urine analysis, and we know that HRS, AKI, ATN in a clinical context, and fractional excretion of urea. And again, we can also identify the type of structural kidney damage by looking at the different parameters in the urine microscopy to identify the origin of this structural kidney damage. Biomarkers are evolving, and we know that there is emerging data to suggest the role of kidney injury molecule 1, liver fatty acid binding protein, IL-18, and neutrophil gelatinase associated lipocalin. And I will not go into the details of it, but yes, we know that there is some literature and some studies which have shown that these biomarkers can help us in differentiating the type of AKI. Now, the severity and course of AKI. So again, while we are managing our patients, we've identified the spectrum, our work doesn't finish there. Every day, it is important for us to look at the course, whether the patient is having progression, whether the patient is remaining in the same stage, or the patient is resolving. Now, resolution, as we all understand, has been shown to be having an improved outcomes, but progression is supposed to be a very sinister complication. So if your patient comes with stage 1 AKI at enrollment, but has progression, so if the patient progresses to stage 3 or goes on to the dialysis, we see that the mortality increases from 50 to 56%. However, even if the patient has come to us with a severe stage of AKI, but has achieved resolution, we can decrease the mortality to 21%, as against if the same patient who has a severe AKI and progresses goes on to development of a requirement of dialysis will have a very high mortality. So therefore, the course also is an important governs outcome. How can we identify course of the patient? So at the outset itself, we can know that this patient is going to have progression versus not. And this was an important study by Pierre Guinness and his group, where they did urine NGAL at enrollment for all these patients. And they showed that patients who had persistent of AKI, they had higher urine NGAL as compared to patients who had transient AKI. And as already mentioned that this is a marker of tubular dysfunction, it was able to differentiate HRS from non-HRS form of AKI. Now, in critically ill, it becomes very, very important for us to identify this progression. And in this particular study, again, I would quote here that what we showed here was at day 7, if your patient of liver disease in the ICU has progression or persistence of the AKI, these patients have a very high mortality at 28 days, as against patients who had resolution or no AKI. So at day 7, whatever is the impact of therapeutic intervention is usually deciding the course and the final outcome of these patients. Now, this is our own data of urine NGAL, and we also showed that cystatin C can tell us at onset, and this is an important, that if your urine NGAL is higher than 1500 and cystatin C above 2.9, we can accurately say that these patients will go on to requirement of dialysis. However, these markers were very poor in telling us which patients would recover versus which patients would not recover. So they were telling about progression or tubular dysfunction or maybe response to therapeutic intervention, but they were not telling us about the recovery status. Now, once we have achieved the recovery, then comes the role of preventing these future episodes. So we have to go for a liver transplant because there is emerging data to suggest that one AKI will predispose these patients to get repeated episodes of AKI. So AKI itself leads to another episode because it damages the nephrons, and with time, it also results in decrease in GFR, and almost 1/3 of these patients will go on to development of chronic kidney disease, which is actually a result of not only the frequency of AKI, it is also governed by the severity, the duration for which the AKI remains, the liver disease severity, and this we showed in this large prospective study of 800 plus patients with liver disease. And it was very interesting to see again in this study that even though if the patient was not developing AKI, so any patient with liver disease, if you follow them up for a year or so, even if they are not developing AKI, they do develop a reduction in GFR, which shows that there is a chronic damage to the renal system as a result of the deranged hemodynamics. And this is a recent paper where we showed that the deranged hemodynamics, that is an HVPG of more than 17, a vasodilatory state, a decrease in SPR to less than 2000, and a low MAP were all predisposing these patients to AKI, repeated episodes of AKI, and CKD, which was a result which resulted in more number of hospitalization and mortality. So how do we counteract that? We can achieve a hemodynamic response, decrease the HVPG, and counteract the portal hypertension. We can handle the vasodilatory state by using either IV albumin or midodrine. So these are the strategies which need to be looked up in prospective randomized controlled trials. So to summarize, ladies and gentlemen, AKI is a frequent and ominous complication in patients with cirrhosis. Use of AKI criteria with incorporation of urine output should definitely be done in the intensive care units. And urine analysis is a very easy test and gives us a lot of information about the spectrum and can also tell us about the course and the response to treatment modalities. The close monitoring, of course, can improve the AKI outcomes. Assessment of recovery is important. We should limit the duration of AKI, the severity, because this becomes a risk factor for future CKD development. Biomarkers are very exciting, but still remain experimental. We need a lot more data to incorporate them routinely into clinical practice. And we do not as yet have an ideal biomarker which can replace the kidney biopsy. Thank you.
That was a great talk, Raki, as usual, from the ILBS, the Mecca of hepatology. Just have two questions. One is, this NGAL and cystatin C, when will they become available commercially? At least we can predict which guys need dialysis, because 33 years I've been treating AKI in cirrhosis. We always get confused about how to go about treating these patients.
They're commercially available.
So urine NGAL, like we are not doing as in, we are routinely doing as in the ICU now. There's a lot of dependence on these tests because it gives us where we are actually debating whether we should dialyze the patient or not. So it becomes easier when we see these biomarkers in a clinical context. It becomes easy for us to go for going for dialysis and such therapies. If the patient is not meeting absolute criteria, when we are planning to do the dialysis, when the patient is meeting relative criteria. So there, these biomarkers become very helpful and we are doing it. The cost of this test comes to around 1,200 to 1,500 at our center for urine NGAL and 800 for cystatin C, and they're very useful for us.
I think Professor P.N. Rao, who's the president, and Acharya Saab was there. I think we should all become, these markers should be available across the country. Now, yes, sir.
Mohan Prasad, this marker is available commercially. You can buy the kits. These are kits-based study, and they are available. And you can buy and establish in your hospital without any problem.
I just made a comment. Thank you. I mean, I completely agree with the Raki, which one should include the urine output in the AKI criteria as well, because when we have, though it's unpublished data, when Dr. Gupta was in Apollo, we have taken out the patients who are creatinine more than 2.5, more than 4 weeks, with a urine output more than a liter. We did the only liver transplant, and when we compared with less than 1 liter of production of urine, we found that the patient, those who were having a urine output more than a liter, though it's arbitrary, but the creatinine been improved in the after transplant and the AKI resolved. But in a patient, those who are urine output criteria, I mean urine output was less than 1 liter, it was they either required kidney transplant later on, or some or other form the kidney injury was persisted. So definitely this urine output criteria must follow or included in the AKI.
When we see, sir, in the ICU dynamically, hourly urine output, the moment the patient drops from 40 to 20, we know that we have to intervene. Otherwise, tomorrow we will see ATN in the kidney. So urine output dynamically tells us to intervene, do things. If the urine is improving, we are happy. Tomorrow the report of creatinine
will come down. Agree.
Raki, have you combined MAC with urine output hourly?
Yes,
that is a very important
point. Is very, very important.
And urine output, well, the patient is calm.
So actually, I did not show. Yes, sir. You're very right. In this study, we actually studied all. I just showed the urine output just not to confuse. But out of the many factors that we found significant of predicting the course of AKI, so mean arterial pressure was one of them. apart from ventilatory failure or respiratory failure, and infections due to MDR infections. So these three and urine output were important criteria apart from systemic inflammation that we got as significant factors determining AKI outcomes.
What is the cutoff which you take for NGAL? Because there are two studies which said one is 290, another is about 302, 30 or something, 300.
Sir,
I
can tell you about the nanogram per ml. This, what we are doing is giving us, there are some unit differences. When you see some papers, they talk about microgram per gram in the Peregrina's paper. We have nanogram per ml, and based on this kit, so cutoff of what we have found is above 400. We see that the patient will have progression, and above 1500, it is more likely that these patients will go on to dialysis. In septic shock, we see around 2,500, 4,000 range of NGAL.
Dr. Rakhi, have you checked serum NGAL anytime in these patients? I mean, there is a pediatric data which talks about serum NGAL, and they look at both serum and urine NGAL.
Yeah, serum NGAL is also a reflection. So NGAL in urine is supposed to be a marker specific for the kidneys, but yes, serum NGAL is also elevated in states of systemic inflammation because of the iron and per se because of that lipocalin protein gene is upregulated. So that data again, Peregrina's group, they have published that serum NGAL is also elevated in this context. But for kidneys, it is better to go with urine NGAL.
I thank Rakhi for the wonderful lecture. And now may I request Dr. Garg or Chaudhary to invite Professor Acharya, teacher par excellence, to deliver the next talk.
Thank you, sir. Now I have to invite Professor Acharya to deliver his talk, the prevention of
reducing the risk of HCC in viral hepatitis.
Yeah, prevention of risk of SCC in viral hepatitis. Professor Acharya.
Thank you, Vijay and Hitendra for inviting me, and thank you, Kausal, for giving me the opportunity. We all know that primary liver cancer, which is the most frequent liver cancer of the most frequent cancer of the liver, is predominantly caused by infections, and it's very well known there are hepatitis B and C. Well, hepatitis B was discovered in 1963 and hepatitis C is 1989. If you see, more than 7 decades have passed for hepatitis B, and for hepatitis C, it is almost 3 decades. And yet you are struggling with, despite knowledge on the virus, the diagnosis, the structure of the virus, the pathogenetic mechanism of liver injury, the interventions develop, right? The reasons for this are many. But as we go through it, we will discuss gradually why we have not been able to control. If you see, this is a very recent slide which was released by World Health Organization in 2018 only, indicating the prevalence of global cancer throughout the world. If you see, hardly any area which is white, where there is no data, or which is gray, that is not applicable. Barring the small island here, the whole world is plagued with liver cancer, and the blue area, that is China or Far East, and some part of Africa. And they have the highest incidence, more than about 10 to 12 per 1,000 populations. And if you see even US, which is about 5 to 8 per 1,000 population, and of course Africa. And if you see, this is underrepresentation. I don't agree, because SCC underreported in ICMR and ARC, and hence we have been placed in below 5 per 100,000. We should be somewhere here. And that is because our reporting is bad and we don't have a registry for liver cancer. But this, emphasizing the point, this is globally prevalent and probably increasing. And if you see, this is also the World Health Organization data, which has been recently. published, more than half till date are because of hepatitis B and C. And if you see our region, this still now is the most dominant cause. There is no doubt that we need to provide attention. Now, if you see the death rate, which is again very recent, we still lose about 8 lakh people, and more than half are because of these viruses. And surprisingly, despite the antivirals and vaccination, the frequency is increasing in all these areas because we have added other habits like unsafe sex, tattoo, IV drugs, and the vaccination, even if it is started, monitoring in this part of the country is inadequate. And till date, the unsafe injection, and most frustratingly, the access to diagnosis therapy, large part. You are not in ILBS, not in Delhi, or not in BG Mohan Prasad Center. That hardly covers 5% of the population. In this country, 95% of the population do not have access to diagnosis. Yet, World Health Organization has a very ambitious aim to eradicate the virus by 2030. And they think the global mortality due to SCC will reduce by 65%. To do that, hepatitis B and C annually should decrease, and the burden should decrease by at least 7%. That is the calculation. And till date, this is 2020, another 10 years left. And out of 144 countries which are registered in World Health Organization, 12 has achieved this target. And only 10 to 20% of eligible patients for therapy for Hep B and C are accessing the therapy. However, one thing is very good in the horizon, that by now, this is World Health Organization data, how far this is true as depends upon the reports from the nation. 84% of infants have at least received 1 dose of vaccination. And it is well known that vaccination itself in China and Taiwan has successfully shown to decrease the hepatitis B virus-induced primary liver cancer. Well, out of hepatitis B and C, HBV is the most important cause till date. Because HBV has a predilection for liver, you know, and most important thing, that once you are infected, even though you have acute viral hepatitis, now various studies have shown chromosomal insertion of hepatitis B virus DNA in area, which produce proteins, which are trans-activating proteins, which cause cell proliferation. And that is the reserve always. And you know the magnitude that about, even though amongst carrier, if you follow, a large proportion will develop chronic hepatitis B, and they lead on to develop cirrhosis and liver cancer in about fairly large, about average 10%. So it is 50 to 50% of global HCC approximately, and has a 15 to 20-fold higher predilection to develop liver cancer than non-infected patients who are vaccinated. And well known that vaccination has been developed in 1980s, and we have multiple antivirals since last 20 years, and which has shown to reduce the risk, but 10% of people are getting it. Obstacles clear, known to all of you: ineffective vaccination in developing country, high perinatal transmission, which needs different type of strategy, parenteral transmission, as I showed, tattoo and drug injections increasing, and access to diagnosis therapy, and lack of national priorities. For example, India, National Hepatitis Control Program is not existing. And to add to the fuel to the fire, we have increased lifestyle diseases. Now there are evidences lifestyle diseases act as a synergy to increase progressive fibrotic disease, which is harbinger of liver cancer. So for hepatitis B, if you see, there are 3 predominant mechanisms for liver cancer. One is genomic integration, as I suggested. After viral infections, the viral replications goes on, which causes genomic integrations. Once there is a genomic integration, you know liver injury in hepatitis B is predominantly immune mediated, and it induces a lot of pro-inflammatory cytokines. And also that perpetuation of infection occur because of leaky gut, and also ineffective innate immune system of the liver to take care of the gut-derived pathogens, as well as the immune-mediated liver injury provides damage-associated molecular pattern, which perpetuates immune-mediated inflammatory response. Simultaneously, we know body has the defense mechanism to start repair, and the repair process is what? Increased cell proliferation, wound healing by fibrosis, and increased angiogenesis, which actually adds to liver cancer for us. While this is happening, this changes the matrix, because there is increased fibrosis in presence of viral persistence. You know about microRNAs, which are now influencing the tumor or tissue microenvironment. Many of the microRNAs has been identified as the aggressor or providing additional factor for cell proliferation and mutations, as well as liver cancer. And persistent of the virus, like hepatitis B X antigen and surface antigen, which has been shown from our center, as transactivating peptides for various transactivating factor, which increases cell proliferation. So these are the three areas. These are the three targets for intervention to decrease liver cancer and hepatitis B. So coming to the genomic integration, major determinants. So the intervention is very, very easy. And in fact, if you see the studies in HCCs, tissues, 80 to 90% of such tissue has shown hepatitis B virus genome. It's a very early event, and the loci has been identified. As I told, they are encoding proteins with potential to initiate cell proliferation. They also affect the epigenetic site, like tumor suppressor genes, and also upregulate proto-oncogenes, which are basically molecular drivers, which you are listening, various molecular drivers against which the therapy for liver cancer is developed. And therefore, obviously, you need all infants to be vaccinated, and for hepatitis B surface antigen positive mothers, addition of HBIG, and high-risk patient to be vaccinated, safe injection, proper donor screening in your transfusion services. I will ask you how many of you actually have tested the quality of the screening, as well as through occult infection, transplant recipients can get infected. So if you see hepatitis B vaccination indeed prevent genomic integration, studies have shown, but so that see this data, this is the old data from Taiwan, which was published in 1997, which compared patients who are not vaccinated till 1984, because they introduced vaccination program in 84. 1980 was vaccination discovered, hepatitis B virus vaccination discovered. I remember reading the smallest articles in NEJ, first vaccine, plasma-derived vaccinations. And if you see the childhood HCC frequency drastically reduced after the vaccination program. This was still 1996 and this data. But if you see the recent data, it has further improved in the HCC frequencies, markedly has come down, as well as hepatitis B surface antigen carrier. And very interestingly, after 2011 in Taiwan, there is no HCC. And just simply vaccination started in 84. And if you see the China, in 80, there are 90% has HBV, either carrier or indirect marker for hepatitis B. In 2020, it is hardly 1%, and it has prevented 3.5 million deaths. Obviously, there is no doubt vaccination preventing integration. Problem is, we have added antivirals to pregnant mothers who are hepatitis B positive at 32 weeks. We have known about vaccine escape mutant. We have known about incomplete vaccination. We have known about occult hepatitis B virus infection. Certain country horizontal transmission where 80% of the infants should be immunized to decrease the burden. And the high-risk vaccination in our country is always neglected in many parts of the country. So these are the reasons why hepatitis B virus associated liver cancer is increasing. So one is preventing the genomic integration. Second is preventing the inflammation. Inflammation is driven by persistence of the virus. And if you see, we know this slide is very well known, that immune-mediated injury, liver inflammation, And recent studies has shown that the persistent elevation of the major driver of TNF alpha and IL-1 beta, that is NF kappa beta, which helps in increased cell turnover, which has been very clear in vitro as well as in vivo, causes mutation. And TGF beta, another cytokine, increased fibrosis for matrix remodulation. Very interestingly is the pass of tissue repair. We know there are two types of macrophages, M1 and M2. M1 produces pro-inflammatory cytokine, whereas M2 tries to do the tissue repair by producing anti-inflammatory cytokine, cell proliferation, angiogenesis. With this cytokine, genomic integrations with genetic changes, this in fact assists SCC formation rather than tissue repair. See how body's defense meant for benefit has added if the virus persists. Very interesting data these are. This inflammation can be controlled. And two very well-known agents, statins and aspirins. These are very recent study. I've given you a short data. This is a chronic hepatitis B, 7,000 patients, followed up 7 years in Korea, who had statin, and they found cumulative dose response reduction in SCC and risk by 70% after adjusting co-founders like age, sex, presence of cirrhosis, antiviral therapy, and other factors. So statin itself was found to reduce the risk of SCC. And the mechanism that has been also studied in some of the study is the potential anti-cancer activity in other cancer types of statins has been shown, and it actually downregulates HNG-CoA reductase, you know that. And that actually prevents a pathway called mevalonate pathway, which are necessary for malignant cell proliferation, knocks off mevalonate pathways, and also inhibit fibrogenesis by decreasing TGF beta and decrease cholesterol synthesis, which are necessary for hepatitis B virus replication if you go back to your studies. So statin actually helps in reducing cancer. The second very important data, which is large, there are small data, but I have given you a large data. In Taiwan, more than 10,000 patients, nationwide cohort study. And there was a significant risk reduction of SCC after adjustment. And it is thought that it actually downregulate PDGF, one of the major drivers for SCC, and also inhibit the inflammatory, pro-inflammatory cytokine. So you can use this agent, and now there are evidences. So vaccine preventing inflammations, and third thing is matrix remodulations. That is the disease state, which occurs because of viral persistence, which changes the tumor microenvironment and provides the transactivating protein for various molecular drivers. And therefore, antivirals are important, but they are not effective in all patients. Therefore, you have to stratify the risk and identify who will be at risk and follow them to detect the early liver cancers. You have know the risk factor very well, host, viral factor, and disease factor. Did not repeat it, advanced age, certain ethnicity, and particularly in our country, Northeastern people. Addition of lifestyle, as I told you, alcohol, have been found to increase the frequency of HCC have markedly. Smoking, as well as presence of diabetes mellitus, we know independent factor to progress for the progression of liver disease as well as liver cancer. Reveal study has shown associated DNA levels with predict SCC irrespective of the status of the disease. Certain HBE positive, certain particular genotype in our country, D genotype, Southeast Asia, it is C, presence of BCP and pre-core mutant. SCV co-infection increases the frequencies of SCC, and occult HBV with SCV, as well as certain people report HBsAg quantitation. It's simply hepatitis B virus persistence, nothing at which transactivate. And if you have an advanced liver disease that we indicating the virus has stayed for long, has caused matrix remodulation, has caused increased inflammation, obviously that is one of the another important factor, which you can detect today by various methods. And if you see, that's why instead of discussing in details, the advancedness of liver disease and persistent of virus can be easily assessed today by transient elastography, which is being available widely in our country. And you simply see that as the liver stiffness increases, the frequency of liver cancer increases, the hazard risk increases. And about liver stiffness, about 19 kPa, all the complications of liver disease increases very much. And in fact, people have found out various scores using the same thing: age, albumin, DNA level, and liver stiffness. Total score is 30. And if you see, as the score increases, frequency of liver cancer at the increases, and they have validated in the derivation cohort and as well as validation cohort at 3 and 5 years. Both validation and derivation cohort has similar matched frequency as the liver stiffness increases. There have been many such predicting factors to identify the stage of the disease, which is use standard criteria like advanced age, low albumin, has presence of advanced liver disease, and HBV DNA levels, right? But these are clinical parameters which can be used. But I thought this is a very interesting predictive score. And this was devised from REVEAL criteria. We know there are a large number of patients in REVEAL who had long follow-up, and about 9% had developed liver cancer. They further went on to include a validation cohort with a large follow-up, in which all practically similar frequency of liver cancer were documented. They were not on antivirals. And if you see, these are sex, they have scored what they did univariate, the multivariate, found out the odds ratio, found out their beta coefficient, and rounded up the beta coefficient to an integer to provide scores, which is a standard way to do the scoring. And if you see, this is the scoring actually. Sex, male is more frequently develop liver cancer than female. The advanced age, for every 5 years, the score increase in age, they added 1, and age started at about 30, because beyond 30, we see predominantly liver cancer. Total score was 6. ALT 15 to 44, more than 44. Presence of E antigen positive or negative, DNA values, and the total score was 17. If you see the score is high, the frequency of liver cancer as the time progressed increased. And when they compared with all the predictive parameters, they have the highest area under curve. ROC was about 0.8 to 0.9. So this is a good marker, but this is not practical. So what happened? There is a group of people who modified it, because DNA is not practical to measure in most patients, and they simply replace the DNA with a liver stiffness score, and remaining score remains same. For liver stiffness below 8, they scored 0. 8 to 13, they give 2, and more than 13, they 4. And if you see, this is the frequency of HCC and liver-related events, they increased as the score reached more than 14. Right, started to increase from 10 onwards. And this is a very practical score, because this is age, sex, ALT, HbEAg, and liver stiffness, which you do day in and day out. And you can identify the risk score and stratify them. And the area under the curve for both HCC at 3 years and 5 years is quite high in these patients. So you can risk stratify actually, taking all these components. And I thought this is a very good score, a modified REACH-B score, which doesn't measure the DNA, instead measure this liver stiffness in advanced age. This is the major component, and very simple. Add the sex, E antigen, and ALT. And that itself will give you very easily. Now, if you see what is happening in such patients, as you allow the virus to persist, allow the inflammation to occur, allow the matrix remodulation to take place, obviously the various pathogenetic mechanism of liver cancer join hands, have a synergistic effect to produce liver cancer. So most important thing, if you knock off viral replication, you reduce the inflammation, which has been proved, and you know it very well. And indeed, multiple studies by now has shown that antiviral therapy given for a long period of time reduce the hazard risks from about 40 to 80% in various studies. And this is actually recently a systematic review which was published in APT, which I saw, which has collated almost all studies. But very important that the risk comes down after giving about 5 years of therapy. The risk decreases after 5 years, right? This only start coming down after 5 years. Till 5 years, almost the risk remains 7, and this need to be followed up. So you have to identify this patient for early treatment, right? To necessary to prevent silent liver injury, and longer duration of therapy is necessary to reduce fibrosis, and fibrosis reversal has also been documented in patients with hepatitis B virus. So essentially for hepatitis B, the primary prevention, genomic integration, is obviously universal hepatitis B virus vaccination, and those HBsAg mother is HBAIG. Antiviral prophylaxis for high viremic mother and other known transmission route, as I told, suggested should be interrupted. Those who has already hepatitis B virus infections, who doesn't have liver cancer, will have benefit from antiviral therapy, but for a long-term basis, and risk stratify for those who have advanced fibrosis for SCC surveillance. I didn't show this data that patient, those who has hepatocellular cancer and undergone curative therapy, antiviral therapy to improve liver reserve, prevent liver failure, and it has been documented to reduce liver cancer therapy. Coming to the hepatitis C virus infection, hepatitis C with advanced fibrosis we know has a high incidence of liver cancer, and those are infected versus non-infected, the cancer incidence is very high. Before the directly acting antiviral, the death rate was quite high, of course lesser than hepatitis B. There is no vaccine. It's an adult disease unlike hepatitis B, but it is easy to treat. It's an RNA virus. It has no nuclear reserve. And who wants to eliminate by 2030? By the standard thing, the donor has screening, safe injection, high risk screening, and access to therapy and diagnosis. If you see the same mechanism which I have played, I did not repeat, and this has been also shown, but particularly I will focus the attention here that certain of the hepatitis C proteins like HBsAg and HBsX proteins can directly, right, upregulate various cell proliferation pathway. We all know these are known pathway. And you also know the risk of SCC in hepatitis C virus infected patients, like same as hepatitis B, male sex, advanced age, co-infections, genotype 3, which is prevalent in our country, and lifestyles. Hepatitis C, the lifestyle adds to increased frequency of liver cancer more than hepatitis B. Smokers, alcohol, diabetes, and non-genotype 3 fatty liver disease. Genotype 3 can have fatty liver disease, right? And so non-genotype 3 fatty liver disease has been shown to increase. And the antiviral, this is a large study. There was initial doubt about this, whether antivirals increase the frequency of SCC, which has been nullified by meta-analysis of all those studies reported and published in 2017, but I'm not giving the data. But if you see the antiviral benefit, that all-cause mortality is reduced by 78%, and SCC reduction occurs by about 80%. These are very recent data of large cohorts of SCB who were given directly antiviral treatment with SBRs. Now, these are retrospective study, what I told, but there are prospective study. Particularly, this was published recently, only last year when I saw this study. This is a very prospective study of large number of patients, more than 7,000 on DAA, with a large 3 years follow-up. And risk reduction over 3 years was about 40%. There are many, many studies like this, And all these studies shows that after SBR, SCC incidence reduced to 1.5 to 2.3% among cirrhosis, right? Which was about 6 to 8% before they achieve SBR. And there are many reports in large cohort, which has been recently collated in recent publications. And I will suggest you to go through it, but it doesn't become zero. Therefore, risk stratification in such patient is necessary, despite they are on directly antivirals. And the risk stratification is not very difficult. You see, the risk stratification base, if you see there is no SBR, if you just take albumin and platelets, right? And if you see the albumin is less than 3.5 and platelet is 1.2 and there is no SBR, the risk is very high. It's about 20 over 2 years. But if you have SBR, see this group, the risk reduces to almost 10 in 20 years. But if you have one of the factor, no SBR, either albumin or platelet, the risk is high. But if you get them SBR, the risk again substantially falls to almost by 50%. And the best group is those who have SBR with good albumin and good platelet. Even if they don't have, if you have good albumin and good platelets, the risk is about 5%, right, in 2 years. But if you treat them, this is very easy. The risk further falls about 1 to 2%. And you can follow them and cure these patients. So despite SBR, based on albumin, platelet, either alone or in combinations, are important indicator for risk stratification, which is very simple, clinically possible in your clinic. And that's why I thought this was a good study. Third thing, again, the inflammatory environment. This is Swedish registry study, which is again recent. And they found those who have on aspirin after adjustment for SBR even, the risk reduction is by 40%, 41%. Hazard risk even 0.69 in comparison to 1, those who are not receiving aspirin. So anti-inflammatory is being shown in multiple studies now to be important. The SBR, with SBR in Hep C by DAs has many benefits in each stage of this disease. If you have chronic hepatitis, halt progression to cirrhosis, very well known, documented now, many studies. If you have compensated cirrhosis, there is fibrosis regression. In fact, certain reversion with reduction of portal pressure, prevention of liver decompensation, obviously that reduces SCC recurrence. But the benefit of SBR is maximum here. So if your early therapy is very important, once he reaches a decompensated therapy, whether SCC occurrence reduces and recurrences reduces, needs data, solid, strong data, which is still NAC. So the benefit of SBR, if you see, is maximum here, which should be used till compensated cirrhosis. So it is obligatory to identify this group of patients. So SCV-induced SCC reduction, I will say initiation factor SCV should be prevented by using conventional method, which is very well known to. And as I saw in the previous slide, early diagnosis and early DA removes your headache. And therefore, access to diagnosis, therapy, cheaper drug, and national policy. V.G. Mohan Prasad is a very influential man in the country as well as in his state. So does Raki's boss and many other people. I think this is very important to introduce the policy as Punjab with Dr. Dhiman has done. Early SCV cirrhosis with DA therapy obviously will show important, but those with cirrhosis, a risk stratification simply using albumin and platelet is very practical. And if you have a lower stiffness measurement, that adds. Thank you very much.
Sir, a lovely talk, sir, and very explicit, very simple to make even people like me understand. So over to Chaudhary for his comments, and then you can invite GC.
Sir, I was like, remember the time I used to listen to your talks like a student, and I still enjoy the same. I would just start with one of the comments by Dr. Setu Babu. He has mentioned in the section that recent data showing tenofovir is better than Entica in preventing HCC. Your comments on that?
Yeah, that's right. That is that based on many things actually. That study, I know there has been study that tenofovir is better than entecavir. Obviously, tenofovir has an advantage because many patients who are on lamivudine, entecavir is a problem because the mutant actually, if you have a mutant, you lose the benefit. And in fact, the mutant actually has been shown to be associated with more aggressive occurrence of HCC. And second thing, tenofovir, unlike entecavir, is already phosphorylated. Both adipavir, tenofovir, and TAF. They are phosphorylated, did not be phosphorylated in hepatocytes. And you need, they do need to be phosphorylated to become active inside the hepatocyte. And these are already phosphorylated compound, therefore they are definitely marginally better. And treatment beyond 7 years, what Dr. Setu Babu is referring, the tenofovir has shown a better result than entecavir. I agree with you. I don't disagree.
Right, sir. Sir, we have been given time till 6 o'clock. It's already 6:05. So before moving to any other question, I would now invite Dr. Gauradas Chaudhary, who is the Director and Head Gastroenterology at FMRI, to speak on something really important, which is sarcopenia and cirrhosis, one of the most common complications in cirrhosis. And let's hear from him regarding the pathogenesis and treatment. Over to you, Dr. Chaudhary.
Right. My slides are visible?
Yes, GC sir, yes.
Right, fine, thanks. Pleasure to be here amongst friends. And, you know, if you have to be a modern hepatologist, then there are 2 or 3 topics which are fad topics nowadays. One is, of course, acute and chronic liver failure, and the other is sarcopenia. So if you are not going to throw these terms around, it means you're not yet arrived on the scene of hepatology. So I'll try to do justice to this topic in a very simplistic way within 12 minutes. Sarcopenia, as I understood it, means atrophy of the skeletal muscles. And you know, it's actually something that happens with age. So when we were all young in our 20s and we used to play football or go to the gym, the muscles used to look like this. And then gradually over a period of time, when you are into your 60s, it starts shriveling up. And that is the phenomena of sarcopenia. We thought that it was of interest only to people in orthopedics or in medicine, but overall, there has been a whole lot of work on sarcopenia in liver disease, primarily led by, again, one of Dr. Acharya's young students, Dr. Dasrati, who also happened to be one of our juniors in JIPMER and then at AIMS. He's done a lot of work in trying to put skeletal muscle as a very important organ in the overall dynamics of liver disease and so on. Now, this is what actually happens in sarcopenia. So you have youthful muscles, bulging, rippling muscles, and then gradually they start getting a little shriveled up and inactive and small. So one of the things is inactivity, and then of course there is aging, and then there are so many other factors. And of late, there are several conditions which have drawn the attention of people who deal with muscles. We all knew that the muscles do shrivel up if you have a bad disease like cancer, but 2 chronic diseases where it seems to be playing a significant role, one is diabetes and the other is liver cirrhosis. When I was doing my DM in gastroenterology in the early 80s, Dr. Acharya would recall, the main book that we used to read apart from Shiv was a book called Sheila Sherlock, Dame Sheila Sherlock's book, you know, on the liver. And she, in a very typical British way, described cirrhotics as lemon on matchsticks appearance. And, you know, I revisit that term. It actually looks like a lemon on matchsticks. In those days, we used to focus more on the lemon part of it. Now the focus has shifted onto the matchsticks part of it. Thin limbs with actually atrophied muscles. So let's come to a little bit of hard facts and what do we take away from this lecture. So how common in liver cirrhosis? So this tells you that it's fairly common, would be to the tune of about 30 to 40% compared to age and sex matched controls. But the other phenomena is that the more advanced the liver disease, the sarcopenia tends to be more profound. So people with child C cirrhosis have a higher prevalence of sarcopenia than the ones with CTP score A. So obviously it's both prevalent in cirrhosis and it tends to worsen as the disease advances. What are the causes of sarcopenia in liver cirrhosis? Well, the list is long. So Kaushal has been very generous in giving me 12 minutes, so I can't go through all of them, but suffice to say, that should be the checklist. Nutritional, role of ammonia, portal hypertension, testosterone deficiency. You know, there is a hormonal imbalance, especially in males, vitamin D deficiency, certain branch chain amino acids which seem to fall short, insulin resistance. So I revisit this topic of type 2 diabetes, inflammation, and this new kid on the block called myostatin. I'll deal a little bit with myostatin for your interest. But coming to the first and most important cause, it's nutritional. And nutrition can't be overemphasized, the role of nutrition. You know, the first time anybody comes to know he has a liver disease, so you have doctors, relatives, neighbors, everybody telling him what to eat and what not to eat. So it's a bit iatrogenic. There is often a loss of taste and appetite. There is anorexia, there is GI bleeding. And of course, you have malabsorption in portal hypertension or decompensation, increased protein breakdown, hypermetabolic state, and GI protein loss. All this you know. And if you look at what happens to the state of nutrition, again, you find that nutrition is severely compromised in people with liver cirrhosis. And just like what I showed for your other features of sarcopenia, it tends to get worse as the disease progresses. So it's much more in patients with child C liver cirrhosis. Now, malnutrition and liver cirrhosis and liver transplant, that has a very interesting association. So I'm sure there would be liver transplant surgeons now who understand the importance of nutrition. By and large, people going in for transplant, about half of them are fairly grossly malnourished. And how does it matter? Why it matters is because malnutrition was found to independently be associated with infectious complications, both at transplant or beyond, as well as before, as well as for hospital stay. So if you actually want to really have good outcomes, there is no other way but to focus on nutrition. And this is a very interesting slide which tells you, so the largest quartile is the one where the muscles are still relatively preserved, and the smallest one are the ones where they're really atrophied badly. And if you look at adjusted 1-year survival for people undergoing liver transplant, you find the ones with slightly better muscles doing far better than the ones with grossly atrophic muscles. So the liver transplant surgeons will definitely understand the implications, and as hepatologists, we need to understand that. So this is again another way of depicting it. So those with sarcopenia, that is with atrophic muscles, they have a rate of post-operative sepsis is fairly high, 17%, close to 20, whereas those in whom the muscles are still reasonably well preserved have a much lower chance of developing post-operative sepsis. So I hope I've been able to impress upon you the need to preserve muscles. And just to end on a slightly more positive note on this particular section, people have realized that if you really work hard with nutrition and try to correct your sarcopenia or malnutrition, outcomes improve. So in this study from 2003 to 2007, you see the rate of post-operative sepsis was 28%, And with fairly intense enteral nutrition, they could bring it down to 10%, which again highlights the positive role that nutrition can have. Now, I'll talk a little bit about the mechanisms of sarcopenia. So there are quite a bit. So I'm not really very enthusiastic about going too deep into the molecular mechanics, but here is it for all of you. And you can see the mitochondria are very important for muscle metabolism, and they play a role. Inflammatory cytokines, they're everywhere. So, but the new kid on the block is myostatin. And I thought that there will be a little discussion on what is myostatin. Now, let us tell you why sarcopenia occurs so often in liver cirrhosis. The body requires energy. So in the normal state, the liver has glycogen, which is broken down by glycogenolysis to glucose, and which provides calories. If you don't have enough glycogen in a cirrhotic liver, so there is not an adequate supply of glucose. So therefore, what happens? You get it from amino acids by gluconeogenesis. And this often comes from muscles. And that's the reason why muscle breakdown tends to be much more common in people with liver cirrhosis. Fats are, of course, another source of calories. But as you know very well, our food fads tell us that we restrict fat in patients with liver cirrhosis. Now, protein restriction is often advised by physicians during hepatic encephalopathy. We feel that the protein is a source of ammonia which goes to the brain. And there have been studies which show that if you reduce protein intake during phases of encephalopathy or during chronic encephalopathy, your figures tend to become adverse. Whereas if you go on giving normal protein diet, the protein breakdown tends to be much less. So regardless of the immediate response that you might have with his flaps, overall restricting protein seems to be fairly harmful for many of these patients. Now I'll bring the discussion to myostatin. Now myostatin is, it's called growth differentiation factor 8, GDF. And it's a protein produced by myocytes. Now, in simplistic terms, if you look at growth differentiation factor, one would expect that the more of it that you have in the body, more the muscles would become nice and bulging. Peculiarly, it works the other way around. It's an inverse relationship. So it works on the muscle's autocrine function, and it's an inhibitor. So it inhibits myogenesis, muscle cell growth, and differentiation. So don't confuse it, in the sense the more of it, the weaker the muscles, the less of it, more bulging the muscles. And this particular GDF8 is encoded by the MSTN gene. Now, these are two pictures which should really stay in our minds. This is an animal, bull, which has a deficiency of myostatin. And you see it's so huge and bulging, I mean, it's muscles all over. And there are humans who also have a deficiency of myostatin. And this is what generally happens to them. So rippling muscles, in fact, certain types of muscular dystrophies are conditions where you have abundant muscles because the myostatin is inadequate. Now let's see what happens in liver cirrhosis. In liver cirrhosis, another factor that comes in is that the ammonia levels in the blood or the body tend to go up, and we know the mechanisms. And ammonia tends to actually, upregulate myostatin. So when it does it, what happens to the muscles? The muscles actually start shriveling up. So apart from malnutrition, low protein intake, now you have an ammonia factor coming in. There is portal hypertension, testosterone, so that long list you should remember. But ammonia is particularly important. And I just want to show you one picture which tells you that in an experimental situation, if you are able to lower ammonia using LOLA in this case, you find that actually the protein breakdown tends to come down and the muscle cells tend to increase in number. So there is a very clear relationship between the two. Now, this is not something that I'm advocating, but this is only to tempt you. So people who want to build muscles, they often turn to the net to get a nice potion which would build their muscles. So I was Googling and I found that in the net, there are a whole lot of myostatin inhibitors which are available. I'm sure most of the gym instructors advise these to be taken by young people, especially in Gurgaon, who go to the gym. They want to build muscles. How effective they are, one doesn't know. But in the realms of the future therapy, there could be a role of using myostatin inhibitors to build muscles if you think muscles are really desirable to mop up your ammonia and so on and so forth. I'll just leave you with only one other word. So sarcopenia deals with skeletal muscle atrophy. But you know, there is a much more wider encompassing term called frailty. So you understand what it means. A frail person, elderly person, frail, you give him a push, he falls. Now, frailty is probably another term which needs to be used more often. It's a clinical state of increased vulnerability to health stressors, and it is associated with reduced physiological reserve. Now, frailty encompasses other things. So there is a neuromuscular component, there's an inflammatory component, there is a skeletal component, and an endocrine component. So many people feel that sarcopenia could be one issue, but overall frailty could be a more larger, wider measure. And this slide tells you that now there are ways of measuring or assessing frailty. So there is a liver frailty index, as you know. Now, it's very interesting. If you look at what is happening to the patients of liver cirrhosis waiting for a transplant, so it's called the wait list mortality. And you find that those who are not too frail, they seem to be able to survive the long waits a little better. And those who are indeed very frail, they seem to drop off during the waiting period. You might well ask me, that what's the big science behind it? It's common sense. But then, you know, actually much of medicine is common sense. So those who are frail are the ones who are obviously much more vulnerable. But this is the way that data can be actually looked at. So overall, I think both the two terms are very similar to each other. Overall, look at it as sarcopenia or frailty. If your aim is to improve long-term survival and good quality of life, both of them need to be addressed. So the take-home messages: sarcopenia and frailty are common in patients with cirrhosis. They're important determinants, not just of survival. You know, we keep talking about survival because it's a much more definite endpoint in science. But remember that quality of life, UNICEF's group was the first to try or assess quality of life in liver cirrhosis. In fact, one of my PhD students worked on it. It's equally important. If you live, you might as well live well. The common causes of sarcopenia and frailty are several, but don't underestimate the importance of nutrition. Look at ammonia, understand the mechanisms that myostatin works, and look at lifestyle. Now, I haven't actually given much time to this, but you know, one of the real ways of building muscles, what do people do in Haryana, for instance? They go to the gym and they do push-ups, or they use dumbbells to build their muscles. And that's it. Actually, if you are doing some degree of resistance exercise, that's one of the best ways to build your muscles. And I think in a therapeutic armamentarium, we should be able to instruct our patients to not neglect their muscles. Muscles of cirrhotic patients also therefore need attention. Thank you very much for your patience here.
Thank you, sir, for the very elaborative and informative talk. Sir, anybody has any question?
I must place on record there are two people in the audience who are very knowledgeable about sarcopenia. One was A.C. Anand. He gave a beautiful talk in one of our NAFL conferences. I still think that was an eye-opener. And Dr. Kaushal Madan. In fact, he was very gracious to help me out with some of the slides.
So far, sir, I mean, the outcome for post-transplant MELD is the best predictor. But we have compared the high melder with low melder, but very high with low. We have measured the muscle mass with the CT scan of L3, L4 level. And we found, I mean, the patient who are frail, they even have a poor post-trans survival rate vis-a-vis the patient who's having a high MELD. So it is not like this MELD, higher MELD is, patient is more frail, but it might be possible their MELD is high, but the patient is not frail. And the opposite way, I mean, where the patient is more frail, they have a higher prediction for post-transplant mortality. So what we are doing, we are placing, I mean, because post-transplant, we do the post-transplant because we are placing a PEG tube for the nutritional betterment within a 7 days after, just whenever the platelet or an INR bit stabilized, we are placing a PEG in those patients, those who are very frail. And we did till now, we have did the 3 patients, and all of the 3 patients were improved. I mean, they're very frail. Their weight were around 28, 29 kg. So, I mean, you very rightly said, sir. I mean, post-transplant outcome is very much dependent on the sarcopenia status, and we must give a comparative trial with the MELD score. Till now there's no study which compared the sarcopenia status with the comparison with the MELD for the post-transplant outcome. We must see, and it's okay, sir. I mean, this is for me fine.
Yeah, I mean, due to shortage of time, I didn't show those other pictures, but I'm sure you would be knowing or in a better position to tell. So a CT scan is sometimes very useful in assessing the size of the paraspinal and prespinal muscles. And there are very elegant studies which have shown that those who have got significant muscles seem to do much better than the ones who have completely atrophic muscles. So this is obviously one of the areas which is now emerging, and we need to possibly pay attention to that.
Excellent, Gurdas. I learned from you as usual.
What is it?
So I guess there are no more questions coming from the attendings. I would request Dr. Acharya for a closure comment and...
Not me, Abhidip. It is you are the chairperson. You and VG should give the closing comment, and Hitendra and Gaurav. You should not ask
I have just question from Dr. Acharya. Sir, you told, I mean, statins reduces the risk factor. I was muted that time. I couldn't ask that question. I was asking, but it was muted. So, I mean, you were not able to listen to me.
Ask. If I know, I can answer. No, ask.
You told us that statins were reducing the risk of SCC. So one should give, in a high risk patient, those who are more than 40, male, even if they are not diabetic, non-hypertensive, the lipid levels are normal, one should give
statins, yes,
in those group of patients.
Yeah.
Aspirin, sir, because
aspirin is maybe problematic, because if you have varices, there will be problem. But well, there are large data now on statins, and I was amazed that statins are actually helping. And suppose in our cirrhotic, a small dose of statins, rosuvastatin, 10 milligram is not going to cause any harm, right? And the problem is statins are known to cause mitochondrial. Now there will be another study that statins may aggravate sarcopenia and increase the death rather than helping the death. You may prevent liver cancer, you may die. So well-preserved cirrhotic giving statins with this data, no harm.
Sir, I think the network issue of Dr. Acharya, which we are facing.
So, so we come to the end of this session. This was an excellent session. We had. Yes, sir.
You're fine. Whatever you people decide, you do.
So we come to the end of this excellent session. We had a great discussion. I thank all the speakers, Dr. Raki Maiwal, Dr. Acharya, and Dr. Gaudas Chaudhary, and I also thank all the chairpersons for chairing this session, Dr. V.G. Mohan Prasad, Dr. Abhideep Chaudhary, Dr. Gaurav Pandey, and Hitender Garg. And I thank all the participants, and I owe a special thanks to Vitrus Pharmaceuticals, which was earlier known as the Mylan, and they are our educational partners. And we'll get back to this room, that is Hall B, at 7 o'clock for liver transplant hepatology course. Thank you.
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 Thank you, everyone.
Hi, Manav. Good evening.
हाय सर, मैं लाइट एडजस्ट कर रहा था बस थोड़ी सी.
एक मिनट वीडियो भी ऑन करूंगा मैं.
क्या हाल चाल है सर जी? How are you?
Yeah.
Sir, good evening.
Yeah. Hi, good evening, Pranav.
Hi. ये लाइव चल रहा है ना अभी?
Hi, Dr. Manav and Saigal. Sujoy here.
Dr. Paul.
हाँ जी सर, क्या हाल चाल है आपके?
क्या हाल है जी?
Very good, sir.
Achha, can you operationalize my video, please? I can't start it. They're saying I don't know why.
Let me check, sir. Let me check. Let me check, sir. Sir, now you see.
No.
I'm sending you a request, sir, to open the video.
Okay.
You came and suddenly gone again and again.
The request is coming, but I don't know.
सर लॉग आउट करके दोबारा लॉगिन करो, हो जाएगा ठीक.
दोबारा लॉगिन करूं?
Yes, sir.
हाँ, एक बार दोबारा लॉगिन करो.
Okay.
Charles Pinnacle. Dr. Joy Varghese. Dr. Joy.
Do we have Will online? Hi, Will. Are you online? Is it Sanjeev?
Yeah, he is online. Dr. Joy, can you come in, please?
Good evening.
Hi, Joy.
Okay. So, Dr. Joy, have you logged in
Hi,
through
Joy,
two devices? Dr. Joy, have you logged in through two devices?
Good evening, Sanjay sir.
Hi, good evening.
Yeah. Hi, Manav.
Hi, sir. Sir,
Hi,
have you
hi,
logged in? Hi, have you logged in through two devices, Dr. Joy?
Yeah. Is it okay?
No, you remove one device, sir. It will echo. You have to remove one device, sir. Else it will echo in the platform.
I see. Now, still it is echo?
Sir, you have.
No, no. See, we can see two windows. Joy, we can see two windows with your name on it. On one, we can see your video. On the other, there's just your name on it. So, have you logged in using another device also, or you just logged in using this computer?
Now it's okay?
Yeah.
No, we can still see the other window.
We still see two windows of yours.
Still it is echo, huh?
Sir, you have to log out from the other device.
Hi, Will. Good evening. Sanjeev, this side.
Good afternoon.
It's a delight seeing you after ages, and it's really wonderful listening to you today.
Thank you so much for the invitation. Looking forward to it. I'm very sorry that I can't stay for the rest of the meeting, but I have other things going on this afternoon that really I can't drop. So my apologies in advance.
Not a problem, but I mean, whatever time you are here, we would really love to listen to you and learn from your wonderful experience.
Dr. Charles, can you come in, please? Dr. Charles?
Yeah, but I'm here. Hi.
Yeah. Sir, your virtual background, you have to remove it.
Shweta, it's good to see you after long.
Yes, sir. Thank you. It's good to see everyone after such a long time.
Bilkul, yeah.
Can you activate my video again, please? I don't know why it's happening.
Hold on, sir. Have you got the request, sir?
Yeah.
Yeah, you're there.
I'm
Hi,
on.
Amma, how are you?
Professor Ela, good evening.
Good evening. Hi.
Hi, Dr. Ela. Good evening.
Bill.
Dr. Sujay, can you come in? I have sent you twice requests.
I think there's some major problem. Can I just join like this? Is it okay?
You are audible perfectly.
We'll be happy to see your face if you can.
Okay, I'll have to link through the phone then separately.
Sir, please do not only one device, sir. Please do not use two devices.
Use only one.
Dr. Manav, I think we have another 2 minutes.
Well, hi. Well,
Hi, Amit. Thank you for your email this morning.
I was just going to say that. Yeah. Okay. Thank you.
I think there's some major problem. I'll just carry on like this.
Yeah, it's
Allow
fine.
me.
Yeah.
Somehow it's not working.
Do you have a different device, Dr. Sujoy, so you can log in with that and log out from this?
I'll log out from here and I'll
Yes.
log on the phone then.
Okay.
Should I try that?
Yeah.
Pranav, my video has been stopped from your end.
You're looking smarter on the picture.
Well, I wish to show my real face, Mohammed.
It is. It's a good looking face.
There am I.
You ready to start?
So just 1 minute, we'll go ahead.
Sure. I mean, Pranav, when you confirm we are live with everybody, then we will start, right?
You are live now, but we'll start in 1 minute. You are live now, but we'll start in 1 minute.
Sure.
Yeah, Dr. Sujoy is in.
So is Dr. Dharmesh, but we can't see his face.
He is here now.
Yeah. It's so good to see you, Dr. Dharmesh. Always a pleasure to see you.
Dr. Dharmesh, can you just put your screen bit tilted towards your face? Yeah, Dr. Sujoy is also in. We are good to go, Dr. Surakshit. You can go ahead.
Good evening. Today we'll start with the transplant hepatology course. So to start this course, I invite the directors of this course, that is Dr. Manav Vadhavan, Senior Director, Gastroenterology and Hepatology, BLK Hospital, New Delhi, and Dr. Sanjeev Sehgal, Director, Hepatology and Liver Transplant, Medanta, Gurgaon. I invite the directors to take over.
Thank you so much, Surakshit. It's a pleasure to invite everybody for this INASL transplant hepatology course. We have 3 very interesting sessions and a galaxy of speakers. The format would be that we'll have the lectures followed by a short discussion, and chairpersons will be actually carrying over the session, and me and my co-moderator Dr. Manav, we would be just like I'm sure we're going to have a very useful and interactive session. Please feel free to ask questions. Also request that all the speakers and chairpersons kindly stay till the end of the meeting. Our session actually ends at 8:30, but I've been told by the organizers that we can have time till 9 o'clock to carry on the discussion, which we will have. I'm sure. So to start the first session, I would invite the chairpersons, Professor Sujoy Paul, Professor GI Surgery and Liver Transplantation at the All India Institute of Medical Sciences, Dr. Charles Pennicle, a consultant in hepatology and liver transplantation, integrated liver cell astrometry, Kochi, Kerala, and Dr. Shweta Singh, Director and Head, Department of Anesthesia and Critical Care, Center for Liver and Biliary Sciences, M.I.C.E. Super Specialty Hospital. So I'll request the chairpersons to start for the.
Thank you, Dr. Sanjeev, for the introduction. And it's a privilege to be here in this session of the INASL, which is going to discuss about transplant hepatology. And we have two very expert speakers, Dr. Joy Verghese and Dr. Will Bernal. With both of whom I am acquainted. With Bernal, with my stint in King's Hospital, long way back, and with Joy because of the several interactions we have had within the surgical community here in India. So, with my co-chairpersons, I would like to introduce the first speaker, Dr. Joy Verghese, who will be speaking to us on nutrition and frailty in end-stage liver disease and how it impacts liver transplantation. So over to Joy, and after that, Dr. Shweta and my other co-chairperson will introduce Dr. Will Bernal for his talk on acute liver failure. Joy, please.
Thank you, Dr. Sujay, and good evening to all. Is it audible now?
Yes, sir.
Yeah, okay, fine. So it's nice to see all of my friends again. Okay, so good evening. The definition of, if you see the sarcopenia in a chronic liver disease, it's slightly different compared with the general recommendation. The sarcopenia definition in cirrhosis is a progressive generalized loss of skeletal muscle, not mass only. There is the loss in strength and the loss in function. But if you take without cirrhosis, the general definition for the sarcopenia is just a loss of skeletal muscle mass. But if you come to the chronic liver disease, mass plus strength and function, there are the three laws. And if you look into the prevalence, in a child A, approximately 10%, and B 34%, and child C 54%. So more or less similar to the decompensation. Whenever the chronic liver disease will get decompensation, we all know the portal hypertension related complication or a hepatocellular dysfunction related complications is progressively increased from A grade to C. Similarly, in sarcopenia also, the prevalence are increasing based on the grade of the liver disease. What could be the key driver for sarcopenia? There is a slight difference in malnutrition and sarcopenia. In the malnutrition, it involves all categories. It will involve sarcopenia, micronutrient deficiency, vitamin deficiency, and all the things. And in chronic liver disease, we will know because of the poor appetite, their intake will be the nutrition-related deficiency, all the etc. Because of the gut congestion, the defect in absorption, there is a defect in storage due to the hepatocyte cell loss and the metabolism defect. But if you look into that, what is the molecular pathology involved in the sarcopenia? One is the chronic inflammation, not only in the liver, there is an inflammation in the skeletal muscle. Hyperammonemia, this per se, because we know the ammonia is converted into the urea in the liver, and this ammonia metabolism will be in the brain also. At the same time, equivalently, ammonia metabolism happens in the skeletal muscle. Whenever the blood hyperammonemia level goes high, because of the defective clearance by the hepatocytes, there will be excessive overload in the skeletal muscle level clearance. So the skeletal muscle, it started to use the glutamine. So the defect in the glutamine because there is a diversion. Okay, the ammonia clearance, the skeletal muscle using excessive glutamine, then normal protein metabolism, protein synthesis, there is the defect in the important one of the amino acids called glutamine. So the protein metabolism is deranged by the hyperammonemia. Of course, endotoxemia. Here it is we all know in cirrhosis, there will be the gut congestion related endotoxemia. And also nowadays it comes as the endotoxemia plays the major role for the ongoing liver inflammation, as vice versa. This endotoxemia also will cause the sarcopenia due to the excessive release of inflammatory markers and the reduced testosterone, the anabolic effect. Normally, the testosterone converted by the aromatase aminase into the estrol, but in liver cirrhosis, there is excessive release of aromatase that will cause the reduction in the testosterone. And the insulin resistant, this is not only in the NAFLD. If you take whatever the etiology of the chronic liver disease, at one point, the insulin resistant will play. That's why we are telling the cirrhotic diabetics. Even though they are not diabetic, over the period of time, there is a more chances to get the impaired glucose tolerance, the cirrhotic diabetics, due to the insulin resistant. This insulin resistant, through the various factors, the pathways, next slide I will show, causing the sarcopenia. Then accelerated starvation. That doesn't mean the overeating. Accelerated starvation means there is increased gluconeogenesis that diverts the amino acids from the other metabolic function. So why I am giving the more important to the key drivers of sarcopenia, if we know their pathophysiology, then we will come to know how to target. If it's a chronic inflammation, okay, how to reduce the inflammation. If hyperammonemia, how to reduce the ammonemia. This endotoxemia, if you know the factor, the proper antidote for this, all the things over the period of time will come as the management of the sarcopenia in chronic liver disease. So sarcopenia, there will be the imbalance between the protein synthesis and the breakdown in a chronic liver disease. Even though it looks like a complex one, but just look into the light green shadows. We all know leucine, isoleucine, valine, all are the branched chain amino acids. This plays various pathways, even including the mTOR pathway, and it is causing muscle protein synthesis. Anabolic steroid, the hormones, testosterone, it increases protein, muscle protein synthesis. Regular exercise through the various insulin growth factor type 1 and various pathway, it increases muscle protein. So branched chain amino acids, we know it will be less in DCLT. The child's grade, it increases. There is a defective. Similarly, the testosterone deficiency will come, and due to that disease per se, they will have a fatigue, and slowly the quality of life, whenever the liver disease progress, will increase. So the poor exercise also will worsen that it will affect the muscle protein synthesis. In other end, if you see the red, other things, the light gray color, these all will increase protein breakdown. What are the things? If you see ammonia per se will increase the myostatin. Myostatin is the cytokine which inhibits the protein synthesis. In other way, we can say it will increase the protein breakdown. So hyperammonemia per se. And if you see the alcohol, even though it is not a cirrhosis, ethanol per se, to the pathway level, it inhibits the protein synthesis. Here, myostatin, endotoxemia, and that inflammatory markers all will increase the protein breakdown. So there is an imbalance by the protein synthesis and the breakdown in chronic liver disease. This is the mechanism. And if you know the factors, okay, what are the factors to inhibit the block, the various level, so we will come to know, okay, how to reduce the sarcopenia prevalence incidence in chronic liver disease. There are 3 myokines are involving in sarcopenia. The myokine means, as I already mentioned, it is a cytokine produced from the skeletal muscle fiber. Most important cytokine released from the skeletal muscle is the myostatin. Whenever the myostatin level goes high, it will increase the protein breakdown within the skeletal muscle fiber. Second, myokine, the cytokine involved in the skeletal muscle is the follistatin. It is exactly antagonist to the myostatin. So there will be a defect in the follistatin. So now the drugs are coming up. There are in the trial. So the follistatin analog. Third, interleukin-6. These three plays the important myokines. And for interesting purpose, there are the studies has come. What type of muscle fiber loss in the skeletal muscle, either type 1 or type 2 and other types, it significantly shows there is a reduction in the type 2A muscle fiber loss. And there is a terminology called cardiac sarcopenia. The meaning itself says, in the absence of any cardiovascular disease, there is a left ventricular muscle, the cardiomyocyte loss, that results in the impaired cardiac function. There are recently the paper started to come out. So we know cirrhotic cardiomyopathy and the alcohol-related cardiomyopathy, dilated cardiomyopathy, but there is called, whatever the etiology, irrespective of the etiology, is called cardiac sarcopenia, that also will affect. So this one I told, there is the type 2 fiber in the skeletal muscle. There is a defect that plays the major role for the. There are the researches going on how to improve type 2A muscle fibers in the sarcopenic patients. So how we have to assess the sarcopenia? Already I told, in CLD, sarcopenia depends on skeletal muscle mass, strength, and the function. So this paper from the Dr. A.C. Anand, okay, it's a fantastic review published in the Journal of Clinical and Experimental Hepatology. So that I'm just here picturizing. How to assess the skeletal mass? We can assess by CT or MRI or DEXA scan, but nowadays the BAA and other things all are inferior than the CT scan. There is trials they are done, and it showed the CT is much superior than the all other modalities through which we can assess muscle mass. How to assess the muscle strength? Here by the hand grip test or knee flexion extension and the peak expiratory flow. The PFT, what we routinely use for the preoperative pre-transplant evaluation to assess the respiratory muscle strength. And if you see here, routine in practice, in muscle mass, we can easily assess by using the CT scan at L3 lumbar vertebral. What about the psoas muscle mass index? And for the skeletal muscle strength, we can use the hand grip strength. But for performance, even though there are the different formats or even the protocols are available, but in our center, there's a 6-minute walk test is equally effective. So we have to ask, whenever we are calculating this, we are seeing the sarcopenic patients in the background of chronic liver disease. So not only the muscle mass, so we have to do the assess the muscle strength and the muscle function or performance test. And this is the picture. Normally, the Hounsfield unit in the psoas muscle will come plus 29 HU2 plus 150. Whenever there is a defective, if you see this is the normal muscle radio density, this red color indicates the plus 29 to plus 150. But if you take those who have sarcopenia, so mostly the red, there is a normal attenuation of the muscle index is reduced to 30%. And there is we go to even minus 32, minus 190. And that earlier I showed there is muscle mass. This is the muscle function or the muscle strength. There are the different scoring systems are available. I'm not going into detail. As I already mentioned, simple is the hand grip test and the 6-meter walk test. These two are more skeletal muscle strength as well as the function. So there are new scoring system nowadays coming. So we know the MELD score. Now there is a called MELD with the SOVA score. This is also logarithmic calculation, and MELD with the CT muscle score, and the MELD with the hand grip test. These are the scoring system nowadays recommended for that assess the severity of the sarcopenia. What about the outcome? Suppose we are doing a transplant in the sarcopenia.
Sorry to interrupt. Can you speed up?
Yeah, please. Yeah. So here, whenever we are doing the liver transplant, in a sarcopenic individual, it increases the hospital stay, ICU stay, and increase the post-liver transplant bacterial infection, as well as the mortality. There are papers are coming, specifically indicates this sarcopenic individual post-liver transplant mortality more in men compared with the female gender. It's quite interesting, but if you go through the literatures, most of the literatures are pointing this message. There is a gender differences there in the outcome in a post-liver transplant. So how to optimize? As I already told, this alcohol, not only the alcoholic liver disease, even alcohol per se, abstinence very important because alcohol inhibits the hepatic ureogenesis cycle and it inhibits mTOR and it upregulates the skeletal muscle autophagy. So alcohol intake, abstinence very important. Diet, of course, we have to all doubling 1.2 to 1.5 gram protein per kg, and the total calorie we have to calculate, it has to be a 35 to 40 kilocalorie per kg per day. And if the evening snacks, as we all know, and particularly here, the importance the branched chain amino acids. So using isoleucine value. So all our patients, if you're sarcopenic, even though all are not, because earlier the paper started to come out with hyperammonemia, but in branched chain amino acid supplementation and the usage of the tube feeding, those who are too sick, rice tube feeding is important. Of course, zinc and the supplement is important. And the exercise already mentioned, showed the picture, it per se, it increasing through the various receptor protein, skeletal muscle protein synthesis. So minimum there is a half an hour walk for 4 days in a week. That is very important. Then normalization of the portal. This is the one of the new interesting. If you reduce the portal pressure, either by a beta blocker or even by tips, even the tips related, almost 6 papers has been published to improving the sarcopenia. So reducing the portal pressure also increasing that's all. So even though the patient not on the variceal bleed, even though grade 1 varices, if they have a significant, the sarcopenic individual, low dose, there is a beta blocker or reducing portal pressure, you have to follow. Ammonia lowering measures, which was initially considered only for hepatic encephalopathy, now it's very clear hyperammonemia per se increases the sarcopenia. So whatever we are using to reduce the hyperammonemia in our day-to-day routine practice, either the rifaximin or the lactulose or the branched chain amino acids, we have to follow those who have sarcopenic individual. Hormonal therapy still under the trial, giving anabolic steroids, particularly testosterone. There are this already mentioned, the aromatase activity wise. There are the innovative therapies are coming up for that various level. Myostatin is the key for the skeletal muscle breakdown. So the myostatin, the monoclonal myostatin inhibitors, and there is a mitochondrial protective agents. These all are upcoming. The last I mentioned, liver transplant. It is very clear, liver transplantation is not at all helpful to correct the sarcopenia, because all the portal hypertension complication will say the liver transplant the cure. Here, with the liver transplant will worsen the sarcopenia, because the patient will be on steroid, calcineurin inhibitor, mTOR inhibitor. This all activates the biochemistry. So this is the last slide. With this, I am concluding my day. This is the paper recently published by Arun Sanyal. So we know the branched chain amino acids, how it helps. Here, along with the branched chain amino acid, adding some more amino acids, and it shows there is an improvement in sarcopenia in both the child A and B category. But by increasing the ureogenesis and increasing the skeletal muscles, and it is altering the nitrogen metabolism. This is the recently published. Thank you. Thank you so much for that.
Thanks, Joy. Sorry I had to interrupt you, but I think we probably have time for just one question. Will you address that?
Yeah, please.
There is one delegate who is asking whether we have any standardized Indian values for muscle strength and the muscle volume, etc., so that we have a standardized way of assessing sarcopenia in our patients.
So at present, whatever we are following for muscle mass is the westernization, based on the Western data. There is the psoas muscle, that index in the male, if it is the less than 50, and in female 36 centimeter per meter squared, means it is called sarcopenia. That will significantly increasing the post-liver transplant mortality. But if you look into the muscle strength, simple as the hand grip test or the 6-minute walk test. That is more than enough for our Indian standard. Suppose if you are seeing a patient, if you ask for 6 minutes, that if they are not able to do that, that itself shows they are definitely, even though the psoas muscle shows normal, there is a defect in the muscle function.
Right, thank you.
Sujay, can I comment on that?
Yeah, please, Manu.
So the Indian data is not published as of now, but we have recently sent a paper to Indian Journal of Gastroenterology. If it gets accepted, you'll have the data. And the cutoff values in Indian population are way below what Westerns have told us. So Joy has very rightly told us 50 for males and 36 for females. In our study, which we did over almost 1,200 healthy people who underwent some CT scan due to some other indication, either acute abdomen or health check or something, we calculated the values, and the values are much lower than the Western values. The female, it came to around 30, and males, it came to around 41. But that paper is still not published. It is in press now.
It's important to benchmark Indian values. I mean, it is in like all these, there are other data also, the BMI, etc. Everything changes, the population that you're taking.
That's right.
So sarcopenia has been in the vogue for the last 2 decades. So why isn't it part of the, say, the MELD scoring and other things, where it can actually better influence our judgment about taking patients up for transplant earlier or decreasing the waiting list mortality? So your thoughts about that?
Yeah. Actually, that's better to take early transplant might be the better than because as it shows the significant post-transplant morbidity and mortality with the sarcopenic individual. But normally, I mean, at present, there is no recommendation so far. So we are following our society, suppose LTSI, our society-wise, slowly we can start the multi-center study, and
yeah,
we
that's a good
will
thought.
be
Yeah.
future. Okay, we can recommend. We will be the role model to the world.
Can I ask a question?
Yeah.
Yeah, please.
Yeah, nice talk, Joy. Thanks. Just want a clarification for the audience. How are sarcopenia and frailty related?
The frailty index all the things based on the performance test. So it is not based on the muscle mass. So that's why I told 3. The muscle mass, whatever we are calculating using the CT scan, it is not at all incorporated in the frailty index. Frailty index totally based on the patients, the performance status. There are different. Some of there is the California frailty index. It incorporates 36 indicators. So mostly there are the questionnaire form. Majority is the questionnaire form. Okay, and some of them physical activity. Okay, so able to get up from the chair, able to say, and able to stand, I mean, right leg and left leg, the movement, with able to stand for a few seconds with one leg. These are the different. Simple in our population, better instead of the following there are so many index FFI, that's why it all simple available is the hand grip strength. The diagnosis.
Can I make a comment?
Minutes walk test. That will be
please.
Yeah, Sujoy, so I think the first question which you asked about this not being a part of our standard workup for transplant, this is because most of us are doing living donor transplants where the waiting periods are very short. So even if you see, you will hardly ever see, though all of us will say that yes, we work on nutrition, so on and so forth, but the time interval from the time of listing to time of transplant is rather short. So you really cannot make a huge dent to the nutritional status of a given patient. Very few times, just because of sarcopenia, you would be delisting a patient. And as regards Ava's question, it's a very pertinent question. So like Joy mentioned, you need the functional test to assess frailty. But you could still be sarcopenic, but if your performance is getting better, you might be considered eligible for transplant. Ava, I hope I have answered that. So you might start with a hand grip of say 21, but you have increased to 24, 25. That would be a good enough time point to take you up, even though your muscle mass is not going to substantially change.
Thanks, Dharmesh. I think the time is up for the discussion. Thanks, Joy. Thanks for the lovely talk. I would like Dr. Charles to introduce Dr. Will Bernal for the next talk. Dr. Shweta, you can come up with manage the discussion thereafter. Thank you.
Thank you, sir. And for the next talk, may I invite Dr. William Bernal. He's going to talk on acute liver failure and liver transplantation. Dr. William Bernal is currently He's a senior consultant in liver critical care at King's College Hospital, London. Over to you, sir.
Thank you so much. It's a real pleasure to be speaking to you today. I'm just trying to get my slides up. Okay, I trust you can see those. I'd just like to thank the organisers for the invitation to speak to you all today, and particularly to Sanjeev. And the title I'll be speaking to today is that of transplantation for acute liver failure. In the 12 minutes that I have allotted to me, I'm trying to cover three aspects of the subject, which I think will be relevant to this audience. I'm obligated to tell you a little bit about the definitions and epidemiology of acute liver failure, where this is relevant to transplantation. I'll then make some observations about the use of liver transplantation in acute liver failure. And I think there are some key elements about the basics of prognostic assessment that are relevant here. And then finally, I'll touch on some new issues on the use of liver transplantation in acute liver failure and how those impact upon the means by which we need to select recipients for transplantation. Okay, definitions and epidemiology. I always use this slide. This is the original definition from the 1970s from Trent Davidson. The three key elements of this definition in red here are still relevant today. This is a syndrome that's happened suddenly, sudden hepatic dysfunction in people who haven't got underlying chronic liver disease that results in liver failure that's so severe that these patients become encephalopathic. And most of the modern definitions we have now use these three elements, usually in conjunction with different thresholds of coagulation disturbance. This summarizes what you really need to know about the basics of epidemiology of the condition. There are three large population-based studies from the West, and I've put in some Indian data here as well. They all say pretty much the same thing. This is a disease of young adults. This is for reasons we don't fully understand. There's a female propensity. Mortality is high wherever you get it. And in the West, certainly it's a rare condition with fewer than 10 cases per million population. Interestingly and importantly, as I'll show you later on, there are key differences from the Indian experience. We don't have the population data, but I suspect it's far more common in the Indian subcontinent than it is in the West. But the patients are considerably younger than the patients in the West, 10 years younger on average, but the same sort of patterns in terms of gender and mortality are observed. And importantly, I think this relates to this slide. The etiology of acute liver failure is very different in India as compared to the West. These are 4 of the more recent larger studies from India, which show pretty much the same thing. 40 to 60% of the cases result from acute viral infection, and fewer than around 10% of the patients with acute liver failure have drug-induced liver injury, and this is principally from antituberculous therapy. And this is the absolute converse of that which is seen in the West, where drug-induced liver injury is by far the most common cause. Viral hepatitis, acute viral infection, is actually a very rare cause of acute liver failure in current times. So the sort of subacute presentations that we see in the West are, I think, very uncommonly seen in India, and this is important in prognostic assessment. So this is a patient with acute liver failure on my unit, slightly historic slide. He's gone to high-grade encephalopathy, so we've intubated and sedated him to protect his airway. We're worried about cerebral edema, so we've put an intracranial pressure monitoring bolt in. He's got cardiovascular failure, so he's got a selection of cardiovascular supportive drugs and some complex cardiovascular monitoring devices. He's got gross metabolic disarray with hyperlactatemia, acute renal failure, and hyperammonemia, so he's on high volume hemofiltration. So he's very sick. It all looks quite complicated, but actually, in essence, what we're doing to these patients is actually pretty straightforward. They get multiple organ involvement. We recognize the different organ systems that are failing, and we give them supportive care. And then we track what happens to native liver function, because in a significant proportion of these patients, actually the liver will regenerate. When the liver regenerates, the multi-organ failure resolves and these patients get better. The ones that we're particularly interested in, where we see a failure of hepatic regeneration, we see progressive multi-organ failure, and these are the patients who are inevitably going to die. And what we have to do is we have to be able to identify these patients as early as we can in their this trajectory, so that we can take them forward to transplantation. And I'll focus on the way we select these patients for transplantation for the majority of the rest of the talk. So it's interesting, actually, if we do select patients for transplant and we take them through to transplantation, they'll do amazingly well these days. These are currently unpublished data from the United Kingdom, nearly 2,000 super urgent acute liver failure transplants. And you can see that since we started doing it in the 1990s, there's been a progressive incremental improvement in survival. This is patient survival, and we're now seeing survival approaching 95, 98% in our patients, approaching that we see with elective transplantation. So actually, we get the right people and they do very well these days. But it's absolutely key to these successful results is to identify the right people. And I'll just take you through some of the basic features that we use to try and predict outcome in acute liver failure. The first of which is the presence of encephalopathy, which reflects critically impaired liver function. So these are data from my center looking at hospital mortality in more than 1,200 patients who've come in with acute liver injury, looking at their survival experience dependent upon the presence or absence of high-grade encephalopathy. So you can see that there's a massively increased mortality in those patients who go to high-grade encephalopathy. If they remain free of encephalopathy, a very great majority of these patients survive. It's not just the presence or absence of encephalopathy that's important, it's also how it presents. These are national data from Japan, 1,200 patients, split by the presence or absence of encephalopathy, looking at survival with medical management. And then in those patients who become encephalopathic, looking at the survival experience dependent upon the interval between the onset of symptoms and development of encephalopathy. So you can see survival in those who remain free of encephalopathy, like the King's experience, is extremely good. If you become encephalopathic, your survival experience is worse. And the longer the interval between symptom onset and the onset of encephalopathy, the worse the outcome is. And so the patients who present with an indolent disease course do very, very badly. And of course, this is all tied up with etiology. The way you present is affected by the etiology of your liver disease, illustrated here with an Indian study. This is recently published in New Delhi experience. And you can see that hospital survival is nearly double in patients who have hepatitis E infection as compared to those who have the more indolent presentations of antituberculous therapy-related drug-induced liver injury. So just if you're making your basic mortality risk stratification, the things that are associated with a high risk of death are the presence of encephalopathy, the subacute presentation of that illness, and particular etiologies we know are associated with a poor outcome. But obviously this sort of broad categorization isn't sophisticated enough for proper transplantation selection. And so what we actually need is a much more detailed analysis of patient features and outcome. So shown here are three of what you might call the legacy predictive criteria for acute liver failure: the Clichy criteria, the King's College criteria, and the Japanese criteria. And you can see that actually they all share some basic similarities, even though the detail may differ. All recognize the importance of age, all recognize the importance of encephalopathy, and all look at the severity of liver dysfunction as evidenced by the degree of coagulopathy. However, there are important confounders here, and I called them legacy criteria because the outcomes with medical management alone have changed very substantially since the derivation cohorts for these criteria were actually evaluated from the 1970s, 80s, and early 90s. So this is survival in patients with high-grade encephalopathy on my unit since it opened in 1973, and you can see that there's been an enormous progressive and improvement in survival with medical management alone since the unit opened. And these observations have also been reproduced elsewhere. This is data from the US Acute Liver Failure Study Group, looking at more than 2,000 patients in their cohort, subdividing it into those who presented between 1998 and 2005 and those who presented between 2006 and 2013. And you can see, if you compare these two cohorts, overall survival has markedly improved when you compare these two eras, but non-transplanted survival has also improved. And these improvements in survival have been seen actually in association with a reduction in the use of transplantation. So fewer transplants, but still improving overall survival. And interestingly, they also observed a fall in vasopressor use, the requirement for ventilation, and various other supportive therapies, including the use of ICP monitors. But an absolute key observation here is that the improvements in medical survival are not seen in all etiologies of acute liver failure. So these are data again from my unit, nearly 1,800 patients with high-grade encephalopathy, split by era, but also by the etiology of liver disease. And what you can see here is that there have been marked improvements in medical survival in the archetypal hyperacute presentation of paracetamol-related disease, whereas the improvements in medical survival are much, much more limited in those patients who presented with more subacute indeterminate disease. And these are the patients in whom liver transplantation is still absolutely life-saving. So recognizing these changes in outcome with medical therapy, in the United Kingdom, we've actually changed our criteria to waitlist patients with acute liver failure. So it's a common misconception that we use the standard King's College criteria. That's absolutely not the case now. We now look at favorable and unfavorable etiologies and then apply a series of different thresholds for the various other measures that we use. And importantly now, in particular, unfavorable etiologies with high-grade coagulopathy, we can now actually waitlist these patients before they become encephalopathic. And recognizing the complexity of actually predicting outcome for patients with hyperacute paracetamol-related disease, we've actually got much more sophisticated ways of selecting these patients, including integration of the use of arterial blood lactate measurements. But these static evaluations don't actually help us with the dynamic course of the patients followed, particularly those with hyperacute disease, such as reflected from paracetamol. This is just illustrated here with two hypothetical paracetamol hyperacute patients, patient A and patient B. If you can see, when they're both admitted to the liver transplant center, it's indistinguishable how they're going to do. They've both got INRs of 4, and actually there's only a slight difference in their INRs looked at 12 hours after admission. But the lines diverge from 24 and then to 36 hours. So actually the clear course for these patients is only apparent after they've been in the transplant center for a while. It only becomes clear after a while that one patient is going to do well by themselves or with supportive medical care, and the other one is going to require transplantation. And recognizing the importance of these dynamic changes, we've developed other models. This is just illustrated here, one we suggested, which was a dynamic model for paracetamol. We looked at 7 variables here, and we looked at changes in 2 of them. We looked at changes in the INR and the lactate over the first 2 days of admission. And what we found actually was that by introducing changes in these measures, we actually improved the accuracy and calibration of the model quite significantly. And these dynamic changes are also recognized in the Indian acute liver failure early dynamic model, which again looks at changes in variables over 3 days of admission, looking at changes in encephalopathy grade, INR, ammonia, and bilirubin. And using this approach, they've actually shown very good predictive accuracy. So just to summarize, this is a rare critical illness. There are key and important differences between the East and West. I think we can safely say that transplantation outcomes are now pretty excellent. Recipient selection remains a real challenge. We've got to make difficult, very time-urgent decisions. And I think it's clear that at least in some countries, medical outcomes are improving. But importantly, this is for some, but not all etiologies. But it's particularly the case in hyperacute presentations. But what we do need are new means for prognostic assessment, recognizing these changes. The basic features are going to be etiology, encephalopathy, and presentation. We refine these through selection criteria. And these selection criteria, I think, have to recognize both the regional epidemiology of acute liver failure, but also differences in case models. And I think we're looking very much at developing dynamic rather than static models, particularly in hyperacute disease. And with that, I'll close. Thank you for your attention and be happy to take any questions. Thank you.
Thank you, Will. That was an excellent talk. And there are no questions in the panel box, so I think I'll get it rolling by asking you that here, as you said, that the etiologies are very different. And, you know, our problem is that these patients deteriorate very rapidly. I'm working as in the intensive care. So my question to you is that as since our etiologies are different, we don't really see a lot of paracetamol poisoning here. We don't see it at all. I mean, I have seen one patient in my entire career. So what do you say, you know, when these patients, when they're sick and they're febrile and we're giving them all sorts of broad spectrum antibiotic coverages, do you think we can give them round the clock cover with paracetamol? Do you think that that is going to make them worsen? Say we have these viral etiologies, the DILI is the 80 used. Yeah.
I think it's difficult, but we would always avoid giving paracetamol to people who've got acute or evolving liver injury. There's good evidence from a number of studies that it may be an important cofactor and worsen liver injury. So it may turn what will be a moderate hepatic insult into a much more significant liver injury. Mm-hmm. So we would always avoid it if we possibly can. And actually it's quite difficult because often our patients are pretty symptomatic. Paracetamol-induced liver injury, they'll often get quite a lot of pain from hepatic engorgement. And they'll be crying out for some painkillers, but we have to avoid paracetamol, and opiates have to be given with extreme caution because they can clearly tip somebody, reduce somebody's conscious level significantly. So it's difficult. But yes, we avoid paracetamol where possible until they're clearly recovering.
Yeah, Will, can I ask a question?
Sure.
Thank you, Will, for your participation, and it was an excellent talk. Tell me, like, you have been working, you know, for 2 decades now, and you have huge experience. So are you looking at some sort of dynamic model in your ALF prognostication and selection? Like, I mean, traditionally, you know, King's college criteria has been used, and the favorable and unfavorable now, which you have modified. Is there a dynamic model which you are also looking at, you know, which you think could be in use?
We are using it. I think what we're also looking at is not relying on a single way of assessing prognosis. If you take a whole, so the models can be used in parallel to support your clinical judgment. What I'm coming towards more is that these aren't final arbiters. They're what you call a decision support full. So actually, it's about your feeling at the bedside and the assessment that you've made of the patient. But you know, it's repeated assessments, and the dynamic models, as we've shown you there, actually do look to be quite effective in supporting that decision making. But actually, you kind of have to go with your gut instinct much of the time, and that's kind of difficult to quantify, I think.
Thanks.
What I would say is that there are some conditions where it's absolutely clear that the patient is going to need a transplant. So if you have somebody who's got a subacute presentation with a small, shrunken, collapsed liver, bilirubin in the 500-600 range, and low-grade encephalopathy, they're not going to get better. There's no way that liver's going to regenerate, and you don't need to make a dynamic assessment of those patients. I think the dynamic assessments will be restricted to those patients who've got rapidly evolving hyperacute disease.
Right.
Dr. Bernal, excellent talk. Charles from Cochin here. I'd like to ask you about your paper on liver volume, CT liver volume assessment in ALF. You have presented, you have published a paper on that. And what's your current cutoffs when you say he's not going to recover or he might recover?
So what we showed from some, but not all etiologies of liver disease, there was quite useful prognostic value from CT volumetry. And in our Western adult population, we found that once your liver volume dropped below about 1 litre, it was very unlikely that you were going to recover if you had a drug-induced liver injury or if you had indeterminate disease. And it appeared that it was very useful in terms of predicting the onset of encephalopathy as well. We don't have it incorporated into our national waitlisting criteria because there's only been one study, our study, which has actually shown that that's the case in a UK population. But again, it's one of those things that we use to support the clinical judgment. As I say, a small collapsed liver with an unfavourable etiology is unlikely to recover spontaneously or with medical supportive care.
Dr. Will, if I may, do you still use the intracranial bolt to monitor the CSF pressures frequently, or because I know in our country it's not very popular?
Very, very infrequently. In fact, my unit has given our bolt away. So if we want to do it, we have to go and borrow one from the neurosurgeons. And I don't think we put one in the unit for on the unit for over a year. Before that, it had been 2 years. So we very seldom use intracranial bolts. I think, again, the experience in the West is probably something somewhat different from that experience in India. We tend to see our patients very early in or much earlier in their disease course now. They're usually well resuscitated by they come to us. They've had antibiotics very early. They've also had N-acetylcysteine pretty early, and they don't tend to develop intracranial hypertension. What we would do is we would perform non-invasive assessments of these patients, and we will do transcranial Doppler evaluations, and we have a much lower threshold for using CT, which we think is a bit safer now. So if we're concerned about somebody's head, we will often do a CT scan and transcranial Dopplers. And on the basis of that, we'll make an assessment as to whether we should think about intracranial pressure monitorable. The other thing that we also have that's very useful is bedside measurement of ammonia level. And if we have somebody who's got an ammonia that's well controlled, they haven't got other risk factors for intracranial hypertension, we'd probably be not too worried about the need for putting a bolt in. But as I say, we don't do it very often anymore.
Can I ask a question? Yeah, thanks for the talk. I just wanted to know whether you use optic nerve sheath diameter for measuring intracranial pressures. What's your opinion on that?
I have no experience of it. If we had it available in our centre, we'd probably be looking at it. We have a very, very good vascular ultrasound department, and they'll do transcranial Dopplers 7 days a week, so that's why we use them. But I know that there are some neurosurgical centres who report extremely good, good discrimination, but it's just something that we're not familiar with.
Right. And what's the last word on non-paracetamol acute liver failure and use of N-acetylcysteine? Do you use it in that setting?
We recommend it. There's some evidence to suggest, particularly in early stage disease, it may be associated with better outcomes. But actually, I think one of the key observations, as I've mentioned at the top, is that paracetamol may be a cofactor in some of these illnesses. So actually giving an acetylcysteine is not a bad thing. And it's an extremely non-toxic drug. So if it's going to make a small difference, the positive difference, and it's not going to do the patient any harm, why not give it? The other thing is that when you give it, you also have to give it in a certain amount of crystalloid, and these patients are often under-resuscitated, and it may be one of the things that means the patients are a little better from a circulatory point of view.
Thank you.
Dr. Bernard, one last question. What about large volume paracentesis in acute liver failure? Do you still use that, or
high volume plasma exchange?
Yeah, plasma exchange.
So we were part of the Danish-driven study on plasma exchange in these patients. And it's been associated, the use of high volume plasma exchange has been associated with improved non-transplant outcomes. We are in two camps, even in my unit, as to who uses it and who doesn't. I'm a little bit ambivalent about it. I prefer to use transplantation. It's absolutely clear that it makes the patients better. Plasma exchange, I tend to reserve for patients who have contraindications to transplantation. So if we've got somebody who's got a really bad psychiatric background who we can't transplant, I would tend to use it in that situation. The problem that you have is that it takes away our most useful prognostic marker, which is to track the INR as a measure of liver regeneration. So it's very difficult. If you plasma exchange, you lose that. So you have to be pretty sure what you think the disease course is before you use it.
Thank you.
Thank you, Dr. Bernal. Thank you, Joy. It was a very interesting session, and we all.
There is a question from Dr. Mathur.
Question from?
There's a question from Dr. Mathur. Dr. Mathur in the chat box.
Maybe we can take it up later. We are already running behind schedule. Maybe we can take up the question in the next session. So before we start the next session, I would request all the chairpersons and the speakers if they can stay back and participate in the subsequent discussion. Now in the next session, we have two very eminent speakers and three equally eminent chairpersons. So let me introduce the chairpersons here. We have Professor Subhash Gupta. Dr. Gupta, can we see your face if you're around? I can see your window. It shows a very beautiful photograph, but we can't see you. Okay, now we can see you. You'll have to unmute yourself, sir. So Professor Gupta is, everybody knows Professor Gupta. He is chairman of liver transplant surgery in M.I.C.E hospital. And he is one of the pioneers of liver transplant in India. The other chairperson, we have Dr. Dinesh Jyotimani. He is director of hepatology in Dr. Rela Institute in Chennai. And we have Ashok Chaudhary. Ashok Chaudhary is a very dear friend and associate professor of hepatology in ILBS, Delhi. May I request the chairpersons to take over, please?
So we have the first talk by Dr. Rela, who of course is well known to everyone. And I think no better person than him to speak on liver transplant for ACLF. So I don't see Dr. Rela here.
I'm here.
Oh yeah, hi, hello. So I could go on and on talking about you. It would be...
No, I prefer not to. And yeah, I mean, I don't know if I'm the right person to talk on a medical subject, but...
I think in the current situation is very relevant to us because more and more patients are getting transplanted for, we are forced to transplant for ACLF, not getting transplanted, but we are forced, isn't it? I mean, this has been
Will Bernal is there. I don't know. Will, do you in King's, is there a lot of transplants for ACLF? At least, is Will gone? Will Bernal? Professor Bernal. Is Professor Bernal, guys. We've all been introducing him as Dr. Bernal. Congratulations.
I think he had to leave, sir, because he had some other session to go to.
Okay.
So he sent in his apologies.
Anyway, thank you, guys. Thank you for inviting me to give this talk. I think I've given this talk a couple of times in the Apostle. Maybe that's why you want me to give this talk. So I was going to say to Will, because when I was in King's as a junior consultant and as a registrar, ACLF would have been a contraindication for liver transplant to an extent that we did one patient, this is probably maybe 25 years ago, who struggled through, and I even remember the name of the patient because we used to look after him so well to get him through. So it used to be so rare. In 1997, AASLD guidelines, it was a contraindication for liver transplant in the Western countries, but that is not the case. And I know Dr. Subhash Gupta a week ago also was telling most people that a majority of the transplants that he's doing currently are ACLF. And very rightly so. I think the outcome of transplantation for ACLF, it's been predominantly driven in the Eastern countries. Even if you look at the literature, most of these are Chinese, Korean, Japanese centers who have driven transplantation for ACLF, and the outcome have actually been pretty good. If you look at the one-year outcome, they're all well over 75% to 90%, which really is not that different from transplantation for acute liver failure or, in fact, even acute in chronic liver disease. The ASAN have done a large number of patients. Even if you look at this series, it's from 1998 to 2010, almost started 20 years ago when it was still a contraindication in the Western world, and they're very clearly shown a 5-year survival for ACLF of 81%. And they have many recommendations, even in this paper, which we are talking about today. Now, my question is, when do you transplant and when do you not transplant for ACLF? I think this is important, and it's actually even more difficult than acute liver failure, because ACLF is a condition where you can actually see spontaneous resolution in almost 40% of the patients, and therefore one needs to clearly understand which one to transplant and which one not to transplant. And it's very clear, really, once you have the number of organ function, organ failure increasing, once the organ failure number is more than 3, then you've got very clearly a mortality close to 100% or close to 90%. And therefore, ACLF has been really, the Europeans have classified them into ACLF 1, 2, and 3, depending on the number of organ function. And I put this Will Bernal's paper of looking back at 3,300 acute liver failure. Apostle actually asked me to write about the lessons that we learned. And it's very clear ACLF requires exactly the same level of multidisciplinary approach with hepatologists, the intensivists, the surgeons, all working together, because a significant number can actually improve here, and the timing of transplantation is very important. Sanjeev Saigal asked about the dynamic nature of assessment. I think it is much more relevant for acute on chronic than it is for acute liver failure, where one needs to be really assessing these patients very carefully in the first week before deciding on transplantation. Now, I like this slide. I've talked about this to people before. I like it, and I would really appreciate that if we can actually put all of if we are collecting our numbers, put them in this manner, just to look at a much larger picture of this. I don't know if anybody knows of the publications where they put, because we have got almost here 400 patients, put in how they recover. So the first row is the initial grade when they arrive, and then what happens to them when you follow them up over a period of time. And this is I find this very useful, because if you look at ACLF1, or nearly majority of the patients were ACLF1, about 200 patients, you will find that almost 50% have got no ACLF at the end of this assessment is between 3 and 7 days, unlike a parcel recommendation where they reassess them at 7 days. This is between 3 to 7 days. And you will find that 50% of them will have no ACLF during that process. And if you move upwards here, sorry, I'm going to, yeah. So you will find that when they have ACLF1, probably around 12% will go on to require, will go on to 3 organ failures, ACLF3, and they will have 100% mortality. So when they arrive even in a good shape to your hospital, it's no guarantee that they will not progress and die. And that's why you need subsequent assessment in order to decide transplantation. And when you look at the extreme form, ACLF3, and you will find that the most of them, almost 68%, will actually will really progress and die subsequently or remain the same. ACLF3 can't progress, obviously. The highest point is ACLF3, and that's why it's not colored red here or colored brown here. So they have close to 100% mortality. So I put this up for you to understand, really think about the indications for transplant. I quite like the way Will Bernal was presenting. He didn't go into criteria for transplantation, but instead he was talking about what determines mortality in these patients, and was making us think about transplantation for ALF even at this stage, rather than coming up with really criteria for transplantation. Now, from this study, actually, you can come to a conclusion that the patients where the 90-day mortality is beyond 90% or close to 100% are very clearly candidates for liver transplantation, and therefore ACLF3 would go into that criteria. If you ask me who are the patients to transplant when they arrive, I would be preparing patients who arrive as ACLF2 or ACLF3, readily really looking for transplantation for these patients. But I'll also say you can't decide that on the first day. You need to be assessing them during the week, and I will go into that evidence in a minute. So the canonic study, you can see there, no ACLF, ACLF1, ACLF2, ACLF3, the mortality steadily increases as they go by. But if you look at the lower two curves, ACLF2 and ACLF3, and if you added transplantation to them during the course of their illness, you see that the curve completely separates out. So the top curve with the good survival is ACLF2 and 3 who have been offered transplantation, and the bottom curve is those who have not been offered transplantation. So you can very clearly see that there is a huge advantages for transplantation for ACLF2 and 3, and I'm not going to go through this algorithm of how, but the point here, the only point I'd like you to see here is whatever the ACLF assessment for transplantation actually have to be, or in the counseling for transplantation should really start as soon as they really are admitted in hospital, provided they fulfill the definition of ACLF. You don't want a decompensated chronic liver disease with sepsis, being very sick, and we are talking about liver transplantation for them. So all of them you need to be thinking of, and you may be removing them later on when you're making the assessment. And here really Professor Serene has come up with this golden window of the first 7 days where you make the assessment to decide about transplantation. And this is the recent paper which has come from really a parcel group and published by a large number. And this is the only point I want to make. The first week is the crucial period for deciding living donor liver transplantation in patients with acute on chronic liver failure. And it's not necessarily the time of admission. And the first week is important. I want to read this out to you. The first week is rightly said as transplant window because of 4 points really. Half of first 4-week mortality, or nearly 1/4 of all causes of 28-day mortality, occur in the first week of admission. Number 2, majority of the patient at admissions were sick and ineligible for liver transplantation at admission, but improved by day 7 once they are in hospital. So actually, the outcome would be better if you actually made them better and took that time in the 7 days. Third point, maximum resolution of sepsis and improvement of septic shock happen. I mean, the point number 2 and point number 3 are probably the same. And finally, increasing, once you go beyond 7 days, there is an increasing incidence of multi-organ failure and death. So that is where you talk about the transplant window. So you assess them on day 1 and you assess them on day 7. And then you decide about transplantation if there is deterioration. Unless they come below ACLF1, you would actually be offering them transplantation. I think I'm going to just show the next 3 slides or 2 slides, which are the slides I put in the APASU consensus meeting. So that will give us really the indications for transplantation and contraindications for transplantation. Right. First of all, I think there needs to be a very clear distinction of the definition of ACLF, and you need to really agree that the patient that you have is actually an ACLF rather than a decompensated chronic liver disease with sepsis. And once the ARC score is greater than 10, I think you can consider them for transplantation immediately. So ACLF transplant is required between 3 to 7 days of assessment, and once they are score of greater than 10, which is ACLF 3, they are clearly indications for transplantation. Now, the other point is eligible grade, this we have said, eligible grade 3 patients are should be considered for urgent liver transplant. Eligible grade 2 patients with no improvement or worsening with medical management on day 7 should be counseled for urgent liver transplant. So we have got grade 3 require immediate transplant, grade 2 require assessment at 7 days and see if they have got improvement or not, and then they need a transplant. And finally, grade 1, if they deteriorate, they need a transplant, but if grade 1 improves, they should be continued with medical treatment. So that covers really the indications for transplantation for ACLF. And in terms of relative contraindication or ineligible candidates would be sepsis with 2 or more organ failures, advanced uremia, high serum creatinine of greater than 4 milligrams per deciliter, or increase in creatinine by 300% from the baseline, or the need for renal replacement therapy. I think these are maybe a relative contraindication. There are patients who get transplanted in renal replacement therapy. Respiratory failure requiring ventilatory support, 4 or more organ failures, acute gastrointestinal bleeding, and finally, probably indicator of sepsis, increasing hemodynamic instability. So that's all I have to say about ACLF indications and really relative contraindications for transplantation. Thank you very much. Shall I stop sharing now?
Yeah. So shall we take the questions now or at the end of the second talk?
No, we can have questions now, Dr. Gupta.
Have I stopped sharing already?
Yes.
Yeah.
First, I might set the ball rolling. I think one thing that I find it difficult is that when we talk about ACLF as a broad category, and we find that hepatitis B and alcohol-related ACLF, they behave quite differently from the rest of the group. Because there is, one is abstinence, the other one there is antiviral treatment. And some of the recommendations that we apply across the group may not actually hold true for these 2 subgroups.
I agree with you. I think if you look at some of the Eastern publications, the best outcomes are actually hepatitis E, acute on chronic or reactivation of hepatitis B. They all quote more than 90% survival. So a large proportion of the ACLF coming from the East is actually hepatitis B reactivation. Whereas alcohol probably doesn't have the same level of survival as those. So just like acute liver failure, etiology also matters in acute on chronic liver failure. There are some etiologies where they do much better than other etiologies. So that fact remains exactly the same as acute liver failure. It's like the drug-induced versus the paracetamol overdose, or even acute hepatitis B do better than paracetamol overdose.
A related point, the majority of the ACLF that we see, Sanjeev and Manav and all the others, the majority seem to be alcohol-related in our country, isn't it?
Yeah.
And whereas the groups are trying to put all together as a new entity, whereas actually it's all mostly 80% of this, maybe more, would be all alcohol-related ACLF. And what are the experience of other places, other centers and hepatologists?
I think the majority may be alcohol, but I don't think most of our patients are actually alcohol. We have a combination of other etiologies as well.
Yeah, sorry to interrupt. Being from the ARG, I can say the majority is alcoholic coming at nearly 50%. But we have analyzed in initial part the Delhi has a poor prognosis of all acute insults. But nowadays it is the liver failure, irrespective of the etiology, that matters most for the survival. So that we are getting. The etiology is not coming significant. It is the severity of liver failure and with complications or organ failures.
But hepatitis B is far better than alcohol. That.
Yeah, A and E has a better outcome. acute hepatitis A and E, we got a much better outcome.
But you mean ACLF because of infection, super infection with A and E has a better outcome.
Dr. Rila, renal problem is, I think, very common in ACLF patients, renal dysfunction, dialysis need. So in a practical sense, like, I mean, what sort of threshold do you have for selection or deselection of these patients when they're needing dialysis? Or, for example, the creatinine is raised to 2.5, 3.
Creatinine raised is not an issue for us, actually. But I think if they preoperatively require renal replacement therapy, I wouldn't be transplanting ACLF unless they come off. Unless they show signs of improvement, I wouldn't be acutely transplanting them. The outcome really are very poor when they are actually on dialysis at the time of transplantation.
Right.
So I think...
see, in the criteria also, in the ACLF, in the organ failure, they have not actually added the renal impairment as one organ failure, in fact.
Correct.
Prof, actually in the canonic definition, the renal failure is single organ only if creatinine value is more than 2. And actually the Westerners don't reckon the use of RRT to be a contraindication. So they think that even if somebody is on an RRT, it really doesn't make a difference to the outcome. Whereas in our country, we probably tend to think differently. So RRT and somebody not coming off RRT before transplant actually has been a negative predictor for most of us.
Yeah, I think the outcome is poor if they are on renal replacement.
So two things.
But that's very different with acute liver failure, though.
Yeah.
You wouldn't worry about CRRT when in patients with acute liver failure for transplantation.
Yeah, because in most of those situations, we are using RRT for non-renal reasons.
Yeah.
So that is probably one of the things. So Ashok, good to see you here. I think two things merit discussion. Both Prof and Dr. Subhash are there. Do you have any idea about what happens to transplanting patients with severe ALCHEP who present as ACLF when they've already been on steroids and then they go on transplant? So that is again a question that needs to be answered, which has not been answered in the Western world. And secondly, because we have been drawing common parallels between ALF and ACLF, what happens to the histology/morphology of these patients once they recover with medical management? So I think these are two key unanswered questions, and that is something that probably the ARC database should talk about, and maybe the experts in the area can comment on it.
Yeah, I can tell we have not published, but we have once thought that we'll give histology score along with MELD, because MELD till now, before the ARC score come up, the MELD score above 27 or 30 has taken as a poor outcome to go for the transplant. But we added the MELD score along with the histology, we're not getting much difference. It is the MELD score is getting much more.
No,
so
no,
that is one odd part.
No, he's talking about recovered patients' histology.
Recovered patients, because in ALF, the histology becomes...
I think that's very important. I don't think even in acute alcoholic hepatitis, the recovered patients are going to have normal histology. Dharmesh, you know that I'm very reluctant to transplant acute alcoholic hepatitis. I'm always looking to see if they are recover, and I have to say we do lose patients like that as well. But I do believe that I've not looked at the histology of these patients, but sometimes I feel that when they recover and go, we have had patients who have been airlifted for transplantation, and I've said that let's wait, and they've recovered. A lot of them have actually subsequently died within a year or so, which has been very frustrating for me. I'm almost thinking that was a mistake to actually manage them medically and send them home. I don't think they would have a normal histology. Do you anticipate a normal histology? Not at all. If they go back to drinking, they very quickly die afterwards. And most of them go back to drinking when they actually recover without transplantation.
So even the favorable etiology, Prof, the HEV superinfection, there also at least the morphology doesn't change on serial scans, which are not difficult to do. So unlike ALF, where the morphology and the histology becomes almost like what it was before the insult when they recover medically, in ACLF that does not happen. But we need to have more experience on this, because serial scans are not difficult to justify.
Now, Dharmesh, can I ask you a question? Now, ACLF1, okay, where everybody says if they become no ACLF, or if they are ACLF stable as ACLF1, you do a medical therapy. But their 90-day mortality is still 20%.
Yeah, so that's correct, because ACLF 1 cannot all be painted by the same brush. So ACLF 1 as per...
Then why don't you offer them transplantation right away?
So ACLF, who's got a bilirubin of 15 and an INR of 3, is very different from a non-canonic ACLF with a bilirubin of 8, INR of maybe 1.7 and a creatinine of 2.5. So therein lies the objective difference in assessment of a patient. So if you see the canonic criteria, anybody more than 12, anybody with an INR of more than 2.5, anybody with grade 2, which is cerebral dysfunction, they would all be counted as ACLF2. But for me, these are patients who deserve only medical management, and a substantial proportion of them will get better. On the other hand, somebody only with a bilirubin of 6, which will not even count as liver failure, an INR of 3, but a creatinine of 2.5, 2.7, or somebody who's got poor oxygenation or needs hemodynamic support, they are a completely different group of patients. So I think we cannot paint them with the same brush.
But then is it not important that you actually categorize ACLF1 into the two categories that you talk about and say that some of ACLF1 will have to be transplanted?
So those are the pitfalls in the existing definition, but I don't publish, you know that. But it's all in your understanding.
Yeah.
So someone with Billy of 15, INR of 4.
Dr. Dharmesh, just, yeah. Sir, I can compliment you. That is basically the difference in the patient selection code.
Ashok, it's getting to be a very interesting discussion, but I think we have to move on. We have taken 12 minutes of discussion in addition to 12 minutes of speaking time.
Sure.
So can I request the chairpersons to, I'm sorry, Dr. Rela. So,
Thank you, Mano. I took a long time for presentation though, but discussion was nice.
Yeah, it was very nice.
I've learned
Thank
out
you.
of it. Thank you.
Thank you. Thank you.
Sanjeev can introduce Dr. Puri.
Right. I'm delighted to invite Dr. Puri for the next talk. Now, Dr. Puri is again very dear friend, and he's a very senior consultant, hepatologist and gastroenterologist, and he's going to be speaking on the very important topic of tuberculosis and liver transplant. This is a very, very difficult topic actually, and I think that a very tricky one. How to deal with tuberculosis and liver transplant, implications on timing of transplant and treatment after liver transplant. So I would request Pankaj to present his views and enlighten us.
Thank you, Sanjeev. I'll just share my screen. Okay, I hope my slides are visible.
Yeah, they are visible.
Good evening, everybody. I'll be speaking on tuberculosis and liver transplantation with a focus on implications on timing of transplant and treatment after liver transplantation. So tuberculosis and liver transplantation, patients are at increased risk, not only because they are immunosuppressed, but after transplantation, they'll be getting further immunosuppression, which may lead to reactivation. And the treatment is challenging. Firstly, there is hepatotoxic side effects of the anti-tuberculosis therapy. They may have a baseline LFT abnormalities, which may confound their monitoring of drug-induced liver injury. And due to marginal hepatic reserve, drug-induced liver disease may be life-threatening. The interaction of anti-TB drugs and immunosuppressive medication is something which has to be considered. So the various clinical scenarios of tuberculosis and liver transplantation is one, a patient who has tuberculosis and cirrhosis and is awaiting transplantation. Second, what if the living donor has tuberculosis or has been treated for tuberculosis? Thirdly, what we commonly often see is liver transplantation for ATT-induced liver transplantation. And finally, a patient who has already received a transplantation and then we detect him to have tuberculosis. So let's talk of the first scenario where a patient who has tuberculosis and liver transplant and is a liver transplant candidate. So how do we prescribe ATT and what should be the timing of transplantation? Now, drug-induced liver disease may be life-threatening if the hepatic reserve is marginal. Here's the slide which compares the effect of ATT hepatotoxicity in people who have normal liver function and people who already have hepatic failure, who have decompensated cirrhosis. The chances of recovery become less once there is already significant liver failure. And that is something which needs to be considered when we start ADT, and choice of drugs need to be considered accordingly. This paper compared the effect of various regimen. And if you see on this axis, you have the various liver Child-Pugh scores, A, B, and C. And here are the number of hepatotoxic ATT drugs. As more and more hepatotoxic drugs were added, the outcomes became worse. And that is the basic reason why we must look at adding the number of drugs in patients who have cirrhosis and we have tuberculosis. The patient has CTP less than 7, Child-Pugh score less than 7, we can usually give 2 hepatotoxic drugs. We must avoid pyrazinamide, and the treatment duration should be about 9 months. Now, here are the people who are probably going in for a transplant or transplant candidates. The Child-Pugh score of 8 to 10, they will usually get only 1 hepatotoxic drugs, and the treatment duration would land up going up to 12 to 18 months. Here, rifampicin is preferred over INH, and pyrazinamide should not be used. We may add other drugs like levofloxacin for another 2 months and try and drop the treatment duration to about 12 months total. People who have Child-Pugh score more than 11, treatment would be without hepatotoxic drugs, and that would include ethambutol, fluoroquinolone, cyclosporine, caprimycin, or aminoglycosides, all with their own associated side effects. The second issue which comes is they already their baseline liver functions are not normal. So how do you define hepatotoxicity in these people who have cirrhosis? Various authors, including Sanjeev's paper here, have made different guidelines or different recommendations of where the liver functions, what liver function we should say is drug-induced liver disease with ATT. But I guess if there's any deterioration of liver functions or clinical deterioration, we must consider ATT hepatotoxicity in these patients. The second issue is, what about timing of liver transplantation? Here was a paper which was published in Annals of Transplantation by Salvador in 2018. They had 26 patients with active tuberculosis, which was 2% of their living donors' liver transplantation. Out of these, 14 patients underwent liver transplantation, even with the presence of active tuberculosis. Now, this is something I will ask you to consider when we discuss what should be the timing and what are the reasons for them transplanting with active tuberculosis. Is either worsening liver status, aggressive hepatocellular carcinoma, or in a few, there was unrecognized active tuberculosis. 3 of these patients were started on treatment pre-transplantation, and 11 were started on treatment post-liver transplantation after oral intake was tolerated. In these patients, you see most of these were pulmonary tuberculosis, and some were extrapulmonary or disseminated tuberculosis. And the various ATT regimen which they used were rifampicin-based, rifabutin-based, INH-based, in varying types of ATT which were given, and immunosuppression dose also was varying in these patients. The presence of active tuberculosis is not an absolute contraindication to transplantation, although initial guidelines had said that it's a contraindication. We must balance the risk and benefit. And even if the patient hasn't completed ATT or has active tuberculosis, you would consider transplantation if he has preferably completed 2 months of ATT, if his tuberculosis is well controlled and the sputum AFB is negative before transplantation, and if the patient has aggressive accelerated liver failure or a recurrent aggressive HCC and it's a life-saving measure. There are also some studies which suggest that post-treatment, post-transplant, the tuberculosis treatment may be better tolerated than a patient who's already a child C cirrhosis. The next issue to look at is, what if the living donor has tuberculosis? Now, we must evaluate the donor in great detail, look at confirming active disease and look at AFB smears, and if the disease is positive, then we must reject this donor unless donation can be deferred until tuberculosis is completed, therapy is completed. And that, of course, is often very difficult in our scenario. Secondly, what if the patient has had active tuberculosis therapy in the past? We must verify whether that tuberculosis treatment is active. If he has pulmonary lesions, we must aggressively look for active disease, and if need be, maybe even a PET for looking for disease activity. Of course, things cannot be so dogmatic. You can't, what if the patient has, if he has lymph node tuberculosis, has finished 5 months of ATT? I think there are many such vexing problems which we can't really put a finger on. The next clinical scenario is liver transplantation for a patient who has ATT-induced liver failure. Now, worsening of some of the issues of transplanting patients who have ATT-induced liver failure are that there may be worsening of tuberculosis once you're stopping the ATT, and there may be increased risk of ATT resistance. You're doing a living donor transplantation. It's a partial graft which may be suboptimal because of the increased metabolic demand. And the post-transplant immunosuppression may flare up tuberculosis. And finally, there's drug interaction of ATT with immunosuppressants. But despite all this, you land up doing it because you have no other choice. It's a life-saving measure. Now, this paper, which was from India, which from Kochi, looked at Amrita Institute. They looked at 7 patients of living donor liver transplantation for ATT-induced acute liver failure. They had a median duration of ATT of 2 months, and post-op mortality was in 2. They restarted ATT after the transplantation only in 2 patients who had prior sputum positive pulmonary tuberculosis. Possibly some of these were empirical ATT, and there is data from India that lots of the ATT hepatitis is probably in people who really don't need it and probably started on empirical ATT. Now, what should be the strategy of anti-tubercular therapy before and after liver transplantation? There is a lot of debate on whether rifampicin should be used because it's going to interfere with other immunosuppression and will lead to acute rejection, and I'll touch on this later. Pyrazinamide fear is there because of hepatotoxicity, and this was an old paper which looked at, suggested that one of the regimen could be INH, ethambutol, fluoroquinolone with or without amikacin. But what is the ideal protocol? So, but we don't know, but it may be even hypothesized that the microenvironment of the new liver, especially with a cytochrome P450 enzyme, may be more suitable to tolerate hepatotoxic drugs, and we should give the regimen as per the patient's condition, not just a blanket one regimen for all patients. So if the patient has received a liver transplantation, there are many ways he could get tuberculosis. One is an endogenous reactivation. Second is if you have a liver which is coming in from the donor derived. And then finally, how anybody else, general public, can get it is a de novo transmission. People who have donor-derived infections, usually the allograft will be more commonly involved and the infection will be early. Reactivation tuberculosis will be more extrapulmonary and more likely to be disseminated. Post-liver transplantation, 1/3 of the people will have drug discontinuation either because of hepatotoxicity or because of drug interactions. These ATT drugs and immunosuppression have a lot of interactions. For example, the commonest one is with rifampicin, but even with other drugs. INH, when we have INH, prednisolone tends to decrease the INH. On the other hand, with rifampicin tends to decrease prednisolone, besides decreasing the efficacy of CNIs and mTOR inhibitors. The fluoroquinolones, when they are used with tacrolimus and the azoles, may have increased QTc prolongation, and they have increased risk of tendon rupture along with steroids. Aminoglycosides we would often avoid in these patients. I'll focus a little on rifampicin. Rifampicin induces cytochrome and P3A4, which will decrease the levels of CNI, but it will also lead to MMF underexposure. All this leading to acute or chronic graft rejection, and many recommendations have been made. One is to increase the immunosuppression dose to about 2 to 5 times with regular monitoring. Second is to use rifabutin, instead of rifampicin, which has less effect on the cytochrome, but there are very few published studies on rifabutin. And finally, don't use rifamycin at all. Now, this paper is from Dr. Rela's group, where they had tuberculosis after liver transplantation in 5 of their 214 patients. And most of these were extrapulmonary or disseminated. They were treated with HRZE followed by INH and rifampicin, and the TAC dose was adjusted. One important point they did highlight was that the explant histology granulomas were associated with development of tuberculosis, and they would give INH prophylaxis for 9 months after 6 weeks in case of granulomas, and if they could find no other cause for these granulomas. I'll go back to this paper on tuberculosis, people who had tuberculosis after living donor liver transplantation. Again, in this paper, they had acute rejection in 6 of these patients, and hepatotoxicity occurred in 2 of these 26 total number of patients. They used varying immunosuppressants, including tacrolimus, sirolimus, and everolimus, and they gave data of individual patients along with what regimen they used in this patient. So that's interesting to see that this needs not be one fixed regimen. You have to compare with each patient's underlying condition and response to immunosuppression levels, as well as the living donor, as well as the LFT. So these are recommendations from various guidelines of what should be the treatment for active tuberculosis in transplant patients. As far as use of rifamycin, all of them say you can use it, though 2 of them have little caveats. They say the European guidelines and the Spanish guidelines would say that you can use it in severe and disseminated tuberculosis, but use the rifamycin-free regimen in non-severe cases where there's a high risk of rejection and those without INH resistance. So I'll focus a little on these guidelines, which say that if you have severe or disseminated disease, it makes sense to add rifampicin or rifabutin plus along with INH pyrazinamide with ethambutol for 2 months, followed by 7 months of HR. On the other hand, if the disease is non-severe, there's a high risk of rejection, you avoid rifamycins, and there the treatment duration would go to as much as 12 to 18 months. But if you add fluoroquinolones or pyrazinamide, you could shorten it down to about 12 months. So there's no one fixed guideline, but this makes good sense. So the treatment of the induction phase should have at least 3 drugs of proven efficacy. And severe or disseminated disease, rifampicin should be included and possibly pyrazinamide. Localized disease, we avoid pyrazinamide and possibly rifampicin. With the rifamycins, there should be weekly immunosuppressive drug monitoring, and we adjust the doses accordingly. We can consider rifabutin instead of rifampicin if there is inability to maintain immunosuppressive levels or rejection. If there is hepatotoxicity with first-line drugs, then the other drugs like fluoroquinolones and cycloserine, etc., needs to be considered. The duration needs to be varying on case-to-case basis, and if there is no rifamycin, the duration is going to be beyond 12 to 18 months, especially if there is disseminated tuberculosis, joint disease, or bone disease. So if you have uncomplicated pulmonary tuberculosis with sputum clearance within 2 months of ATT, you can possibly give 6 months of therapy if you're using the full regimen. If there's bone and joint disease and severe disseminated disease, the duration should not probably be closer to 9 months. For CNS disease, 9 to 12 months. If there is cavitatory disease, if they are continuing to be sputum positive at 2 months, then at minimum duration should be 9 months. To conclude, the presence of active tuberculosis infection is not an absolute contraindication to liver transplantation. Liver transplantation may be considered in active tuberculosis if patients develop accelerated liver failure, aggressive or recurrent HCC. It's not necessary to complete tuberculosis therapy before liver transplantation, but as far as possible, we should try and make sure that the patient completes the 2 months of induction period and the sputum AFB becomes negative at the time of transplantation. Treatment of tuberculosis after liver transplantation mirrors the treatment in general population. However, the treatment is typically longer and more complex due to drug interactions and the risk of hepatotoxicity. Thank you.
I think this is one of the best talks I've heard on tuberculosis. But before I begin the question answer for this session, Dr. Mathur has been a little upset because the questions that he put in the Q&A, none of them are, the chairperson. So I'm going to quickly correct that first. And these questions, all of you can see it. The first question, Dr. Mathur, is if somebody has ALF and crosses the 8-week limit by a few days, should he still be considered for super urgent listing? Second is, should ACLF be prioritized for DDLT? And what rules of abstinence applies for alcohol-induced ACLF? So quick answers to this from from Dr. Rela and Dr. Sehgal, and anybody else who wants to answer these questions. The three important questions. One is ACLF more than 8 weeks, and ALF more than 8 weeks should still be considered. I mean, I think it's questions more, sometimes important in organ allocation so what should be the answer to that?
I don't understand. Why are we confusing ALF with abstinence?
No. His first question is on ALF, and his third question is on abstinence. The three separate questions by Dr. Mathur. Maybe we can, we can answer.
Mohammed, you can summarize and you give a summary of these question answers.
I mean, he's talking about definition of 8 weeks limit.
His allocation of organs. Somebody is in ALF, but I think the Bombay group have defined ALF as being encephalopathy within 8 weeks. I mean, that's the problem. And therefore, somebody crosses 8 weeks, then he or she will not be considered ALF. I think that's what his question is. And therefore, he should not be entitled to super urgent.
Somebody the original Trey and Davidson. Your seronegative hepatitis don't become.
Dr. Subhash, can I answer?
Yeah.
Sure.
All right. So for ALF, which is more than 8 weeks, and most of the subacutes, we all know that encephalopathy might not be present.
Yeah.
And if at all they have neurocognitive impairment, mostly it is related to sepsis or renal dysfunction. So clearly, this is a cohort which is not well served by super urgent listing. Even in the living donor setting, this is also the cohort which is most difficult to handle because you are not sure whether continuing medical management would be of benefit or not. The policy that we feel, and Prof has been a part of that for a very, very long time.
After 8 weeks, they should not get super urgent listing.
So they are a different cohort altogether. So they cannot be.
ACLF be prioritized in DDLT.
Yeah. The second question is about ACLF being given priority for super urgent listing. Again, this is a regulatory question more than anything else.
And the third question is abstinence rule that are alcohol-induced ACLF.
So that is again, each unit will have its own policy.
But you can't apply abstinence rules for alcohol.
If I may interrupt, I think Dr. Mathur has asked these questions. They are more like regulatory questions, and I think they are pointed towards practice in listing patients in this, and
rather
than guidelines on those.
Yeah, can I give a...
I mean, Abba, I'll tell you, we have a time limitation because we'll have to have Dharmesh's talk after this, and there's more talk.
Sure.
So I think that we will have to discuss this tuberculosis part, if you may allow me now, and because we have 2 more lectures after that, and we will honestly run out of time. So, Dr. Gupta, is that okay?
Absolutely, but I think he does a question. He said that anyway. I think we've answered his questions.
Yeah, I think we have got a question, and Dharmesh also said that. Rela also agrees that these are regulatory questions, and I think we cannot fix nothing on that.
We're not policy making bodies.
Yep, absolutely. I mean, tuberculosis. I think. Let's. Dinesh Jyotimani, you have published.
Sanjay, I have a question. Pankaj, that was an excellent talk. Actually, it's a very tough topic. You made it look so easy. I have a question. Somebody who gets ATT and then develops liver injury and undergoes transplantation for liver failure, and then we give it for 9 months or 6 months. How do we actually monitor the progression or the regression of the tuberculosis? Say, for example, abdominal tuberculosis. We don't have much modalities in terms of CTing or, because it's mostly present acidic fluid. Somebody has started the ATT, patients develop liver failure and then undergo transplantation. What's your experience on that? Is Pankaj
the answer lies in you look at what the disease process is. Is it pulmonary? Is it acidic fluid? And if the acidic fluid is not responding or the pulmonary lesions are not responding, then you have to look for drug resistance. You have to see why the primary lesion is not responding. I think you're not going to look at the bacteria. You're going to look at the primary lesion. If you pick up the bacteria, it's a bonus. But more likely than not, you will not pick up the mycobacterium in the lesions so easily. The regression of primary lesions is important. The disease activity needs to be important. If it's a pulmonary lesion, which is a cavitary, the cavitary should be filling up. There should be scarring and fibrosis happening there. Those are things to look for. Of course, other subtle markers like ESR and fever and clinical responses are also there. But more than anything else, the response of what is the primary site of tuberculosis, that should be responding.
Because many times you see patients get started on the ATT because acidic fluid showed high lymphocyte count, and then you end up transplanting that, and then you find, okay, you treat in the post-operative period, and then you're left with no markers for,
So,
you know what I mean? It's very...
it's there, the basic diagnosis of tuberculosis was in doubt.
Right.
There, if you're not even restarting ATT, you would probably not be wrong. Many of these people who have, say, SBP, and they land up getting ATT and liver failures, they never needed the ATT in the first place.
Absolutely.
Pankaj, what is your take on TB prophylaxis? So somebody who's being worked up for liver transplant, and you find that there is some telltale sign, some mediastinal lymph nodes are there and they are reported as necrotic, or the imaging is characteristic of TB lymphadenopathy. What is your take on TB prophylaxis?
If you have necrotic lymph nodes, probably do a EUS and put a needle.
So if we,
if you have a reasonable suspicion, there should be an INH prophylaxis. It is not that pure simple INH prophylaxis is without its own risks. It is associated with its own risks. But if the patient is grossly decompensated, not tolerating that INH, it may be better to transplant and give him the ATT thereafter.
I agree with this point about doing the transplant if it's indicated, and treating TB at a later after the transplant. The new liver problem accepts the.
Dr. Puri, Dr. Puri, one of the you told that there is donor transmitted tuberculosis. So, what should be your screening protocol in a live donor setting for the donor?
See, the most of the guidelines for donor transmitted infections are recommending that we do either MON2 and IGRA along with X-ray chest. We're not doing it in our routine practice, and I don't know how many centers are doing it for the donors. And if they have latent tuberculosis, they would be going on to ATT in these patients. As far as donors go, ideally, if there is no active tuberculosis and there is evidence of latent tuberculosis, you'd probably look at the liver when it's going in and see if there's any granulomas. If there are no granulomas, you're unlikely to transmit from the liver itself. But till the transplant happens, the donor should be on INH prophylaxis.
Does the same thing hold true for recipients as well? Screening recipients?
For the screening recipients as well, the recommendations are there to look for latent tuberculosis and keep them on ATT, on INH prophylaxis till they go in for a transplant. Again, it's the tolerability of the transplant.
Good. Thank you, Pankaj.
Thank
you very much. It was a very interesting session, and thank you, chairpersons. I think we'll have to move on to the next session, which is again very interesting, and I'd like to invite our three eminent chairpersons for this session. Dr. Vivek Bis, Director Liver Transplant and HPV Surgery, Fortis Hospitals, Noida. Dr. Abha Nagral, Senior Hepatologist, Pediatric Liver Specialist, and Liver Transplant Physician, Apollo and Jaslow Hospitals, Mumbai. And Dr. Prashant Bhangoi, Senior Consultant, Hepatobiliary Surgery and Liver Transplantation, Medanta University. May I request the chairpersons to please conduct the next session. Thank you.
I think I'll start by introducing Dharmesh. Dr. Dharmesh Kapoor has been active. He's known for his witty and profound statements. And he's going to be talking to us on immunosuppression in liver transplant, minimization versus withdrawal. He is the chief hepatologist at Yashoda Hospital, Hyderabad. Dharmesh, please.
Sorry, a little bit of a struggle trying to get my slides.
Dharmesh, you may have to open your PowerPoint first and then share.
Yeah, Prof, I already did that. Okay, now
You can see it.
We
can you see the slides?
Yeah, just go in the full view. Yeah.
Sure. All right. So,
Yeah, it's fine now.
Right. So you can't see me, that's good. So I think this particular talk is a talk which is very close to my heart, though I'm not an immunologist, and I'll basically be talking about principles rather than what we actually need to learn from published literature on this, which I think none of us is doing, though we are in a unique position to contribute to research in this area, because most of the transplants that happen in our country are the living donor way. And therefore this particular concept of immunosuppression withdrawal is offered in this setting more than in the deceased donor setting. So we all know that the advent of the newer immunosuppressive agents was actually the defining moment in not just liver transplant, but in all solid organ transplants. And it favorably affected the outcome of these recipients substantially, so much so that whatever was considered to be an experimental procedure became the standard of care. But we also know that it has been the Achilles heel of solid organ transplant, in the sense that this immunosuppression leads to a lot of problems in the recipient, and it's almost like creating a new disease in the organ recipient, which could be renal dysfunction, metabolic disorders, malignancy, the recurrence of the earlier malignancy for which transplant was done, or the de novo malignancy, and so on and so forth. So what is really important is that long ago we knew that there were some patients who stopped taking immunosuppression and still they were able to retain their graft. And this was a kind of a post facto information about what we now know as immunosuppression withdrawal. So this happened more commonly in the pediatric age group than in the adults. And the ballpark figure that has been mentioned in published literature is about a decade or so after transplant for the adults, and about 6 to 8 years in the pediatric population. You might have instances of recipients going off immunosuppression and still having stable graft function. So how do we come to this concept of immunosuppression minimization or withdrawal? This is because not all patients that we transplant, they need similar degree of net immunosuppressive state. So please remember that maintenance immunosuppression is mostly not one drug, but at times at least two drugs, which is anti-metabolites and a CNI. And we at times do the drug levels, but that does not give us a complete handle on what is the net immunosuppressive state. So that might be very different from what the trough level of a CNI tells you. There are some patient characteristics that hold sway. Traditionally, we have all learned over the years that patients with burnt out alcoholic liver disease, patients with the hepatitis B virus related end stage liver disease, they are typically the ones who don't reject, and therefore you could get away with lower immunosuppressive doses. There are certain disease characteristics which hold sway, and important amongst this is transplantation done for patients with acute liver failure. In more recent times, acute and chronic liver failure also. This is again an unpublished and undiscussed area. And patients with autoimmune liver disease who actually need more immunosuppression than the other etiologies of chronic liver disease. However, in most patients, the attempt at immunosuppression minimization should be tried after a period of stable graft function. So much of what we learned in the liver transplant arena came actually from the renal transplant, because that used to happen much before the liver transplants became the standard of care. And quite a lot of it was actually trash for us, because we started to use very high trough levels of CNIs in our patients with liver transplant, which were really not needed. So the famous Ojo publication of New England Journal of Medicine, which tells you that after small bowel transplant, the most important renal dysfunction happens in liver transplant, is probably a publication that might not stand its ground today, because we all know that much lower trough levels are good enough for patients to have stable graft function. So is liver an immune tolerant organ? And I think the answer to that is yes. So if you see this cartoon of liver, we know that the acute rejection, even if it happens in liver transplant, especially if it happens early. So mind you, our concepts of late ACR are now changing. It really does not materially affect the graft survival or the patient survival. Hyperacute rejections are extremely uncommon in the liver transplant scenario. Chronic rejections are uncommon. And even if you have a biopsy proven chronic rejection, if you catch it in the earlier stage, you can reverse that to almost near normal graft function, though it might not always mean near normal liver histology. We now tend to use much lower trough levels of immunosuppression. And we know that if you transplant somebody with both liver and kidney, and traditionally the renal transplants need a lot of immunosuppression, you can get away with much lower doses of immunosuppression provided the two organs come from the same donor. And of course, we know that if you were to use the HLA matching, then it really does not mean much in the context of liver transplantation as it does in other solid organ transplants. So what are the immunologic criteria for what we call as the operative tolerance in these patients? So in this solid organ transplant, what is meant by operational tolerance? So two things are important, as you see in the right part of this slide. What is called as an early immune quiescence. So in liver transplant, in the early part of the post-transplant period, we use aggressive immunosuppression. So what it really does is that whatever are the alloreactive cells which get transmitted into the recipient from the donor graft, they get killed. And therefore, they are not able to attack the graft and they are not able to home in. The second one is the inactivation of immune reactive clones, which basically means that the maintenance immunosuppression is low key. So that means if there is something which has survived the earlier onslaught of high immunosuppression, it will tend to go and home in into the bone marrow. So much so there is a kind of a mixed chimeric state between the donor and the recipient. And therefore, you will have a state in which the donor cells are there in the bone marrow, but they are really not attacking the graft. So this is basically preventing rejection, even though you have some degree of microchimerism in these patients. And most important in all of these things is that there are now some typical signatures. So please remember, whatever I'm talking of is post facto. So this is what have been seen in patients who stopped taking their immunosuppression, and then they were studied to see as to how they were different from the other group of patients who were continuing to take immunosuppression and who needed that immunosuppression so that there would be no acute cellular rejection. So three things have been found in these particular signatures. One is that these patients have got a different kind of a dendritic cell, which is the plasmacytoid dendritic cell. Most importantly, most of these patients have got high circulatory levels of the Tregs. So we all know that Tregs perform a suppressive function. We are all aware of the role of Tregs in autoimmune diseases, graft versus host disease, and they are of extreme importance in operational tolerance in the context of liver transplant. What is the most basic way of saying that somebody might not reject even if you were to stop immune suppression? That is shown by what is called as the cell proliferation. So if you have a stimulation index of less than 20 at more than 10 years of transplant, it's almost absolutely certain that you probably need no immunosuppression for this patient and he won't reject. In the interest of time, I'll not talk of the other things, though it has been shown that even the genes which are important in iron homeostasis, they also have a role to play in operational tolerance. So what are the various agents that have been used in the past to have a recipient accept the solid organ transplant with very low doses of immunosuppression or immunosuppression withdrawal and still not reject? So you see a host of things mentioned on this slide, but I would be focusing only on the Tregs because this is now something which is catching our fancy, and this is now also a subject of good manufacturing practice to be made ex vivo and to be used in the transplant recipients. So the most compelling study came from this Japanese experience, albeit in a small number of patients. So the starting cohort was 40, but only 10 patients could actually be considered for this study. So what was done, and all of these patients received, the recipients received the left lobe grafts. So the authors, they took the donor's lymphocytes as well as the recipient's lymphocytes and they cultured them prior to transplant. So basically the irradiated donor cells as well as the recipient cells, they were co-cultured, and that is what generated a very pure population of Tregs. And as you can see in this cartoon, these patients were treated with standard immunosuppression But unlike the hematopoietic stem cell transplant, they did not have any marrow ablation, but they only used cyclophosphamide one time on day 5, and then this was followed by the cell infusion, the pure Treg cell infusion on day 13. And then once these patients had a stable graft function, they started to lower the immunosuppression. And in most of these patients, they were able to do that. 7 out of these 10 patients, and the 3 patients in whom they could not do it were all patients with autoimmune liver disease. So this is the schema of the study protocol. So you had the donor lymphocytes which were irradiated, you had the recipient lymphocytes, they were co-cultured at least 2 times. And as you can see, that yielded almost a more than 80% pure Treg population. On the bottom left, you see the Treg surface markers, and this is for those who are very clued into immunology, but suffice it to say that it is the topmost, the CD4, CD25, FOXP3 Treg cells which are important, and these are the ones which have got a suppressive effect. So you see this almost similar to a mixed lymphocyte reaction, and what is important in this is the second bar. So if you see that the recipient cells or the donor or the third party cells with the Treg, so you find that the inhibition or the stimulation index is much lower with the donor antigens. So that means this particular suppressive effect of the Tregs is only for the donor antigens. It is not for the third party antigen, which is extremely important because you just don't want to lower the immunity of this recipient to everything else. And they found that as they diluted the Treg population, this effect was lost. So what is told to us by this experiment? A, it is doable in the living donor setting because you have access to the donor lymphocytes. B, the population of Tregs that you are infusing is extremely critical. If this population is below a particular cell mass, then probably it's not going to work. And 3, it's not non-specific antigen alloreactivity that is lost, but it is only to the donor antigens that you lose this alloreactivity. So these are the 3 key takeaways from this study. When they looked at the percentage of cells as well as the number of cells, they found a huge variation. So this is something that we have to bear in mind before we get carried away by the results of this experiment and start thinking that it is something that we'll start doing with the next patient. So as can be seen, the 7 out of 10 patients only could achieve operational tolerance, and they were off immunosuppression for a period of 16 to 33 months. 3 out of these 10 failed operational tolerance, and all of them had an autoimmune liver disease. There was no difference in Treg numbers in circulation or their phenotypes in those who had operational tolerance vis-a-vis those who did not have operational tolerance. And this is the biggest stumbling block in making it a standard of care. There were 2 patients who had operational tolerance but still developed DSA or a donor specific antibody. And if time permits, we will talk about that. What is the impact of DSA and outcome of liver allografts? And what do you mean by the immune post-transplant hepatitis? There were 2 operational tolerant patients who still had a hyporesponsive MLR, mixed lymphocyte reaction, but they still had no histological injury. So if you read this slide again and again, you will find that even though you did achieve operational tolerance, but the basis or the physiologic mechanism which was producing that was not clearly known in spite of 7 out of 10 patients achieving this. This is a study which got published recently, as recently as 2018. Again, you can see these trials are extremely difficult to conduct. So starting cohort was 286 patients, but ultimately only 95 patients could be enrolled. And as you see in the bottom of the slide, only 10 out of these 286 patients could be immune tolerant. However, I have a problem with this study because it was done in the pre-DA era, and hepatitis C is a very trick virus when it comes to diagnosing ACR versus viral recurrence, and maybe that might be one of the reasons why these results are like this. So what were the authors able to achieve by way of immunosuppression minimization? You see in these bar diagrams. So you start to reduce their immunosuppression sequentially every 8 weeks, and this is a good practice point for all of us, especially when the graft function has been stable and you are at least 6 months into liver transplant, and you can achieve operational tolerance in at least up to 10% of patients that you start to do this. These are the consortia for those of us who get interested in this. So Immune Tolerance Network, one study in kidney transplant, withdrawal of immunosuppression in pediatric recipients. There is a European consortium which is reprogramming immunosuppression to establish tolerance. And last but not the least, which is THRILL, which is Prof. Center's trial, which is doing Treg infusions with good manufacturing practice. This publication came very recently in this year only. And unfortunately, again, there were huge problems in conducting this trial, especially in the deceased donor setting. And also because a number of the recipients, they received the DCD grafts rather than the DBT grafts. So can immunosuppression withdrawal become the standard of care? The answer sadly is still no for us, but however, we should definitely try to see if we can lower immunosuppression in these patients. So this is the schema as to how we might approach a patient who needs lowering of immunosuppression, and we might be able to achieve the stage of operational tolerance. Please remember that for want of time, we cannot discuss about specific immune suppressive strategies. They are different for those in whom you want to use OT and vis-a-vis those in whom you want continuation of maintenance immunosuppression. And I thank you for your attention.
Thank you, Dharmesh, for that very conceptual and clear talk. I think we have time only for one question. We are really running out of time. Any questions on this?
I think, well, Dharmesh, very nicely presented. Amazing as usual.
Can I ask a question, Dharmesh, quickly?
As many as you wish.
No, we have only time for one question. Is there any way to predict pre-transplant as to which patient you can go on a low immunosuppression? Is there any way to?
So unfortunately, no, though the traditional concepts have been that patients who get transplanted for burnt out alcohol-related liver disease and hepatitis B, they typically have a lower chance of rejection. But we know that all these things, those with renal dysfunction have a lower chance of rejection. But we know that these are very, very subjective criteria. So one can see rejection with sepsis, one can see rejection with renal failure, one can see rejection even in patients who've been transplanted for ALD. So there is no one good objective way of telling who would and who would not.
Dharmesh, just a small question. In your practice, there are many centers who use to start with even, very low immunosuppression. And some centers, they target level of 10 to 12. So what is your strategy and how do you think these patients are different? And because both the centers claim that their outcomes are good.
Right. So you've had a chance to work with our program, and I've always been an advocate for very low immunosuppression, because I think in the country that we live in, it's far more difficult to handle sepsis than rejection. And rejection generally won't end up killing a patient unless you are a really bad physician.
So in my practice also in strategy, we don't pay heed to levels, trough levels initially for initial few weeks. So that's actually we go by liver function test. If they are normal, then of course we maintain the low immunosuppression.
So the pediatric population that we transplant and those who've got an allograft dysfunction, these two should remain an exception. So for those who have logged in, these are the only two category of patients in whom drug levels have got a meaning. So if you have got an allograft dysfunction, you can be surprised by the level of CNI trough level that you might get, even when you think you are using a minuscule dose.
Okay. Thank you, Dharmesh. I think we need to move on. May I request my co-chairpersons to introduce the next speaker?
Yeah. So Prashant, you can do.
Sure. So I think our next speaker is Dr. Kaisar Raja. He's a senior consultant in hepatology and liver transplantation at Aster CMI in Bangalore, and he's going to deal with the gamut of things that happen probably 3 months after a transplant. And there's always the query of ACR, whether it's a CR, whether it's a disease recurrence. And I think probably you'll also add in the concept of a late ACR in these patients. So Dr. Kaisar Raja, your
thank you, Prashant, and thank you to INASL for this wonderful meeting. Let me just share. Are my slides visible?
Yeah, you're visible. Your slides are visible. Just go on slideshow. Yeah.
So,
okay.
So it's probably the last talk of this session and of INASL, I would say, this meeting. After Dharmesh has spoken very elegantly about immunosuppression, minimization, and withdrawal, we still know that a small minority of patients would have hepatic allograft dysfunction. Now, we exactly don't know what percentage, because we are now on this pathway of immunosuppression minimization, and there's really no protocol for graft. So I'm sure the next 10 years would give us some important information about immunosuppression minimization versus allograft dysfunction, which would happen in this setting. Now, having said that, chronic liver allograft dysfunction is still the leading cause of late allograft loss and mortality. And late hepatic allograft dysfunction can be due to more than one etiology. So it could be both rejection as well as disease recurrence. And all in all, the alloimmune mediated injury has an important role, even if the disease recurrence is there. Now, clinical experience and liver biopsy interpretation is very important when it comes to managing these patients. Now, this is an old study, and here if you can see about 800 odd patients followed for 12 years, liver-related causes of long-term mortality was the maximum number. But I have a suspicion that in this series, hepatitis C would have been there. So as of now, the numbers may not be that much. More important are cardiovascular and malignancy. Now, in but we must still from the early graft dysfunction might keep on troubling us in the late graft phase also, mainly surgical issues which might be vascular and biliary. And residual issues may persist beyond 3 months very well, and they might just complicate the overall picture. For example, you might have an ongoing subtle biliary issues along with the chronic rejection 3 years down the line. Ischemia reperfusion injury would not cause a long-term effect in at least a majority of patients. Acute rejection, if it's a single episode or 2 minor episodes, may not be a problem, but a severe acute rejection may have consequences. And CMV especially, in a situation which is less common, at least in our country, which is a donor positive recipient negative setting, where we usually would give prophylaxis, sometimes would have recurrence after the prophylaxis period of 3 months is over. Now, let's start with a very straightforward case. This girl had an LDLT, she's a 16-year-old, had an LDLT 3 years ago for autoimmune in some form. We don't know exact details. She was an immunosuppressant with tacrolimus and low-dose steroids because of her supposed autoimmune cause. She had normal graft function till for the next 2.5 years, which is 6 months ago, and she started gaining weight. Her blood sugars were elevated. She was having mild increase in AST/ALT, and she actually underwent a graft biopsy, which was reported as tier 2 hepatitis. So assuming that it is post-transplant NASH, her steroids were stopped and she was asked weight reduction. She did both these things. And incidentally, she developed COVID, which she was absolutely asymptomatic. The entire family was affected. She had absolutely no symptom. She continued the same dose of tacrolimus during COVID. About 4 weeks later, because she was monitoring her liver function, the AST/ALT went up to almost 300 to 350. The GGT and ALP went up marginally. Bilirubin was normal. Marked increase in globulins and IgG were seen. And when we looked at her old LFTs 6 months ago, her IgG and globulins were elevated at that time also. Probably something was happening which was missed at that time. A repeat liver biopsy was done. Post-transplant graft dysfunction, abnormal LFT, what it could be. In the current situation, it could be COVID-related, although she had asymptomatic infection. We have to rule out acute viral infection. Also looks unlikely in this situation, but still we have to rule it as a protocol. Could it be a recurrent disease, which is assumed to be acute autoimmune in her case? Is it some form of rejection, whatever we call it, late acute rejection, some form of chronic rejection? In certain situations, we have an entity called de novo autoimmune hepatitis. The terminology has been changed, but still an autoimmune hepatitis developing in a patient who never had an autoimmune etiology. Could it be a biliary or vascular issue, which is unlikely in this case, but yes, this is the overall list which you need to keep in mind when you deal with patients with delayed graft dysfunction. So her liver biopsy showed a moderate portal lymphoplasmacytic infiltrate, mild interface hepatitis, focal endothelitis, scattered lobular inflammation, mild cholestasis, very non-specific type of biopsy, but with mild portal fibrosis, notably no bile duct loss, no steatosis now, minded she has lost weight, and no of these findings. So overall, whatever form of graft dysfunction happens in delayed period, the immune related causes always have something going on here and there. It could be some form of rejection. It could be recurrence of an autoimmune disease. There is an entity called chronic non-specific hepatitis, which actually has an immune basis. Some patients, especially pediatric patients, have graft fibrosis, sometimes cirrhosis. In the absence of a primary disease recurrence, this is also an immune basis. And of course, our de novo AIH. Certain other diseases, viral hepatitis, alcoholic steatohepatitis, and non-alcoholic steatohepatitis, although typically non-immune, also can interact to have an immune kind of interaction with the in the graft. Now, this is very important. This is from the Banner Working Group on Liver Allograft Pathology. I think all hepatologists who deal with transplant should have a detailed reading of this paper in 2016. The older terminology where we used to say acute cellular rejection is now called T-cell mediated rejection. The humoral rejection is called antibody mediated rejection, and the de novo autoimmune, and there's nothing called plasma cell hepatitis. It's probably same as plasma cell rich rejection. So talking of few things like acute rejection, which we now call acute T-cell mediated rejection. About a third of patients will have one or more episodes of acute rejection. Most of them would be mild and easily manageable. Important to remember is the difference between acute and late, early and late acute rejection. In early acute rejection, it is a predominantly portal-based inflammation, mixed infiltrate. So you will see neutrophils, you will see eosinophils. Everything is happening at the porta unless until you have missed it and things go into the parenchyma and the central venules. But mostly it's the porta. There's inflammation of bile ducts, inflammation of portal venules. In the late acute rejection, although it is still portal predominant, but the infiltrates are usually mononuclear. So lymphoplasmacytic infiltrate, less of eosinophils and neutrophils. The involvement of bile ducts and portal venules again less unless until you have missed it. The interface hepatitis is predominant. So there's lots of overlap between the so-called immune hepatitis, chronic late acute rejection. Carefully, there'll be prominent lobular hepatitis and sometimes around the central perivenules, what we call central perivenulitis, which is an important sign of late acute rejection. Now, younger patients, children are more prone. If you have an autoimmune etiology, you're more prone for acute rejection in whole. Retransplant because they get sensitized. A positive T-cell cross, which is usually not done, but if you have information, then that is an important marker that your patients might have more rejection later on. SLA mismatch, which is again not done. Preformed DSA, which more and more centers are now testing, could be a risk factors for late acute rejection. And of course, live unrelated versus related, probably because of the HLA match issues. For late acute rejection, the most important reason is poor compliance with immunosuppression. And as Dharmesh was saying, immunosuppression weaning. Now, we would be weaning a lot of patients, and that will be one important reason for late acute T-cell mediated rejection. And sometimes, very importantly, which could have been a cofactor, no way to prove, was some form of rejection. Now, the chronic T-cell mediated rejection, what we classically known as chronic ductopenic rejection, occurs in a minority. That 17% is a higher number. It's mostly children where it is reported, but usually it's about 1 to 5%. There is progressive bile duct involvement. You may not have symptoms. You might have subtle cholestasis which might be picked up, and then you might biopsy these patients. It usually depends upon the number of previous ACR episodes, the severity of ACR, somewhat donor-recipient mixed match, and autoimmune etiology again. Chronic rejection can be controlled if you pick it up early, but if during advanced stages, despite enhanced immunosuppression, may eventually result in graft loss. Now, here it's all about the bile ducts. You have obliterated vasculopathy, but medium large arteries, which are not picked up on routine biopsies. Here, important to remember is that ductopenia is not accompanied by ductular reaction, as you find in many other causes of biliary obstruction. And by definition, the bile duct loss should be in more than 50% of portal tracts. And here, it's again important to see that absence of ductular proliferation or significant periportal fibrosis helps to differentiate this entity from many other cholestatic diseases, which might come, for example, chronic, anastomotic strictures. We don't do it, especially in adult, but children, pediatric, many centers still do it. Histological abnormalities are usually present in late post-transplant biopsies, and about a fourth of children and even a fourth of adults would have some changes. And many non-specific terminology has been used to describe these features: late rejection, late hepatitis, de novo autoimmune hepatitis, idiopathic post-transplant hepatitis. We really don't know how to tease out these features, but probably the current concept is there's some sort of immune-mediated injury happening, which defines all these terminologies. Now, this is the most recent update. We used to think that antibody-mediated rejection is quite uncommon in at least hepatic transplantation. But recent data suggests that AMR actually has an important role, and there is an entire terminology, which has come around that in the latest BANF recommendation. Acute AMR still remains uncommon. Chronic AMR is less well-defined, but it is now being strongly linked to the presence of DSA, and this could be not just preformed DSA, but de novo DSA, which have it is usually associated with late onset acute T-cell mediated rejection, and this is probably, many of the immune hepatitis and non-specific hepatitis which people reporting could have a role of chronic antibody-mediated rejection, and this probably needs a lot of study in the future. So basically, it is slow evolving low-grade lymphoplasmacytic portal perineal inflammation. See the description, accompanied by unusual fibrous patterns, but variable C4D deposition, which usually we have not seen in our previous biopsies. At least we have not looked for it. So this is something what in a standardized reporting fashion should be looked for in the future in such patients. Now, quickly, recurrence of autoimmune liver disease is common. Roughly a fourth of all your autoimmunes would recur. The recurrence is worst for PSC because that has the most rapid progression and usually no proper treatment. It is the most easiest for PBC because despite recurrence, they still survive long, and is intermediate for AIH. Mostly it is when you are tapering steroid, bring down to a lower level for some reason or the other, or stopping it, that they would have recurrence. It's again more common in children. They've got more about 1 to 2 years post liver transplant. Of course, you need a complete analysis of the liver biopsy, the clinical cause, response to treatment, to figure out whether it's autoimmune liver disease or some other cause. The autoimmune markers, although may not be positive, but not very helpful because they might be coexisting. And a lot of these patients actually develop autoimmune markers, but still don't have biopsy features. So mere presence of high titer autoimmune markers should not suspect a recurrence, although you must be watchful. Again, there are a lot of risk factors for AIH recurrence. Many of them have to do with the HLA, DR3, DR4 positivity and a mismatch between recipient and donor. But most importantly, patients who've got concomitant autoimmune disease around the time of transplant, if they already have inflammation, high AST/ALT, high IgG, or their explant showed a lot of inflammation and plasma cells, then you have to be watchful, keep them on higher immunosuppression. They are the ones who might recur early. This is one entity which is again uncommon, and mostly it was reported at the time when adults were receiving interferon for hepatitis C. It is more common again in children, happens few years after in a past history of AIH. But here, many authors have suggested that an increased percentage of plasma cells, more than 30% in the portal infiltrate, is diagnostic of AIH, and probably here CD138 staining, which stains positive for plasma cells, might be helpful. Now, coming to our young girl whom we had this problem post-COVID, we did not know what her primary disease was, so probably we treated her as recurrent or a de novo AIH. Her ANSMA was positive in low titers, not very high, but her IgG was markedly elevated, which probably made us suspect autoimmune etiology. We increased dose of steroids, added as happened about a couple of months. Her ALT has come down, not to normal, at least to 40 and 50. We continue to follow her up. Now to disease recurrence. HCV recurrence is not a problem. It used to be a nightmare when interferon was used for HCV recurrence. Now with early DAA use, usually HCV does not lead to long-term morbidity. Dharmesh also pointed out that HCV and rejection is a very difficult thing to diagnose on liver biopsies. HBV in selected patients. There might be situations where you might still have hepatitis B, so we will always test when there is a clinical situation. There might be situations where the donor might have been anti-HBC positive and it could be a donor-derived infection. You may not know that the donor anti-HBC positive happens sometime in cadaveric transplant setting when the HBC was not done for donors, and patients may present with a flare roughly 3 to 4 months after the transplant. In these patients, we will not discuss it about, but they all need lifelong antiviral prophylaxis with antiviral. NAFLD is again one thing which can present after transplant. A lot of patients who are transplanted for NAFLD will develop fatty liver, and about a third might have full-blown NASH. Now we are still transplanting recently for NAFLD and NASH, last 10 to 15 years, again a slow disease. We don't know the rate of progression. We know that the intermediate term mortality and morbidity is not there, so probably not much emphasis has been given. But we are coming to know that recurrent NAFLD occurs early. But still is a thing which is under consideration. Sometimes we have rare problems. This was a patient who was actually having something like a rejection. Look at his AST/ALT went up from 36 to 450. ALT looked like almost like a rejection, or maybe a biliary problem. GGT went up to 1600. But his biopsy actually showed NASH, very bad NASH. We still gave steroids for whatever worth it was. But I still follow him up about 2 years down the line, and he still has features of NASH on a repeat couple of biopsies as well. Alcohol relapse is not a big problem, but usually about 5 to 8% patients have early onset heavy use in the first 2 to 3 years, and they may actually present with acute alcoholic hepatitis, which might confuse the picture because usually these patients may not reveal that they are consuming alcohol. So you need to keep it in mind and question again and again, do proper social evaluation. Not to forget, rarely even CNIs are associated with cholestasis. Very difficult diagnosis to make. You come across it once in a while, but you have to be astute. If you're not finding any other cause, might as well convert the CNI to is rarely used, but you do use it in children sometimes, and that can sometimes present with notoregional hyperplasia and sinusoidal congestion. The whole issue is how to monitor graft function long term. We still monitor liver blood tests, that is a liver function test, but it does not give you a complete picture. And we still don't have any other way of monitoring graft function clinically. There is no consensus on protocol liver biopsies. There is no clinically available marker of graft function. Elastography is picking up. It might have problems in living donor transplant, but then we have MR elastography. This might help us in following up patients in the future. As Dharmesh said, once again, there is no reliable marker for overall immunosuppression. So we really don't know how much immunosuppression we are giving or what a patient needs. But what is important is that whenever you do biopsy, our pathologist should use standardized reporting of liver transplant biopsies as per the BANF criteria. And possibly we should start looking more into antibody-mediated rejection when it comes to chronic graft dysfunction. So concentrate on these confusing topics of late acute cellular rejection, de novo autoimmune hepatitis, idiopathic prostanoid hepatitis. Probably they are all immune-mediated injury, slightly different patterns, but we don't really know what patients actually have on different forms of immunosuppression. We even don't know what are the therapeutic strategies in each of these slightly differing entities. Of course, the role of chronic AMR has to be better defined, and reporting of liver biopsy once again must be standardized. Thank you.
Thank you very much, Dr. Kesar, for that very comprehensive talk. I would agree that 12 minutes is not going to be sufficient to deal with such a vast topic, and thank you for doing such a good job of summing it all up. I have one comment and one question for you. I think, again, the two topics, your topic was stressing again on the point of how much we can withdraw immunosuppression and at what time we can start withdrawing the immunosuppression, exactly like Dr. Dharmesh spoke about initially. Because I can tell you over the last 2-3 months, we've had 3 patients who came to us with CR. They normally come in crops, and we had to retransplant them. So it's not so simple to, come down on the immunosuppression even after a long period of time. So do you think that there is a time point at which, and this is to both to you and to Dr. Dharmesh, a time point at which you can think of really starting to come down on that immunosuppression to a single drug 0.5 BD or even 0.5 alternate day, as we've seen in some patients who are more than 10 years down the line and still doing well, normal LFTs with 0.5 alternate day, though I don't really know if it really means anything to give them 0.5 milligram alternate days.
Yeah, thanks, Prashant. It's a very interesting question for hepatologists who follow patients beyond 5 years. There is a very catchy situation here. The immunosuppression problems actually start when you're giving them high dose in the first few years. Now, patients who do very well for 10 years on low dose immunosuppression, you can probably withdraw it in 100%. But the problem is, what is the point in withdrawing after 10 years? All the damage has already been done in the first 10 years. And it is also said in the first 5 years, criteria, you have to follow up your patients. Even the LFT is important. People who maintain chuck normal LFT, no episodes of rejection, alcoholics, slightly older people, have no other metabolic issues, probably are the ones where you can really come down. If you look at the ASLD guidelines, they say that after 5 years, all transplant patients who have not had problems with rejection at all and of non-autoimmune etiology can actually win a very low dose immunosuppression without even monitoring of the TAC levels. So I think there is a role, but what we need to dwell further is how to monitor graft function. Is it just LFT? And maybe we have to really come down on the AST values. Maybe this 25, 30 is not okay, 15 is better. So this needs research. And then the role of elastography. Is elastography going to show up or some other non-invasive marker? If we can find these type of modalities, probably we can monitor patients better and then try to come down slowly on their immunosuppression, possibly stop it. I can't say more about that. Maybe Dharmesh can add a bit.
So I think, Dr. Prashant, your question is a very valid one. You do burn your fingers every now and then, and in the COVID era, there have been some scattered cases where you've tried to stop the immunosuppression, and you found that these patients had a rebound after they recovered from their COVID pneumonitis. So I think the most important thing here is the patient's awareness and patient compliance. So we have patients who take immunosuppression maybe once or twice a week, and we have a good number of those patients. But we know that these are intelligent patients and their attendants would comply to whatever. So even though Kesar mentions that there is no good way of assessing graft function, but 2 things are very well known. So we know that patients post-transplant can have liver enzymes which are single digit, which we never talk of. So this is what we call as supernormal LFTs. So if in the same patient, if 7 becomes 35, you have a reason to worry about, even though it will be in the normal range only. And 2, when you have an allograft dysfunction, which is only characterized by enzyme elevation, vis-a-vis allograft dysfunction with bilirubin elevation, the 2 mean completely different things. So the former, even if you have got enzymes going up to 20 times of upper limit of normal, is readily remediable, whereas the latter, even if you have got enzyme elevation of just 3 to 4 times the upper limit of normal, but bilirubin is 3 to 5 times the normal value, these can be far more challenging. So I think each patient and each case would need a very different kind of an approach. And many a times we tend to overlook what the explant had to tell us. So again, I think because we hepatologists have nothing to do except talking. So you can always go back and, see what the explant had to tell you. And that should also figure in your notes. So because these patients, when they are on long-term follow-up, you tend to forget what happened to this patient in the immediate post-operative period. So it's always a good idea to mention in their prescription every single time if there were some key features of note in their explant. So I think that's what I would do in my practice.
Can I have a small comment?
Yeah,
Kaiser, Dr. Kaiser, very nice presentation and alluded to all the aspects. So in practical scenario in post-transplant patient, when we face these problems, I don't think there is a transplant pathologist here in this forum, but we hardly get any answers from pathology because we rely on biopsies for all these diagnoses after ruling out the technical aspects or technical complications. And once we get a report back from a pathologist, we hardly have, varied methods for treatment of different diseases like autoimmune or so. In most of the instances, what we play is interplay with immunosuppression, either give more immunosuppression or less immunosuppression. So I think just a small comment that we should have some, some meeting with pathologists to, as you rightly pointed out, to streamline the reporting of this and to reach some conclusive diagnosis after we get the biopsy, because that is the most worrisome area when we shoot in the dark after transplant. I would like to hear comments from eminent hepatologists from here.
Vivek, this is a very
Vivek, I totally agree with you that this is something which is really lacking in our Indian transplant hepatology practice. It's not that we don't have good pathologists. We have good pathology, and sometimes we have had very good answers from only pathology. We have been struggling. I would say recently we had a patient who had only bilirubin elevation with enzymes around 40, 50. And he has a history of biliary stricture, ATT for tuberculosis, and as well as rejection in the past. And this hepatology, this transplant pathologist said this is drug induced, absolute drug induced, and he was on INH, but no enzyme elevation. Enzymes are like 40, 50. And we stopped the INH, and today I came to know his bilirubin was down from 10 to 5. So, the pathologists sometimes really.
And Dr. Vivek, actually, we also treat them very shabbily. So we just tell them that allograft dysfunction enzyme level is this, and give them the complete history. So I think the only way out is for us to be seeing our slides if we have time. So probably
I still remember, I agree. Manav used to go and sit with pathologist and see slides himself. And that was really commendable of any hepatologist who is in collaboration with the pathologist that would provide the answers.
I mean, that's absolutely a standard practice in like our center also, that pathologists, like they will interpret a slide based on the data you provide. And we always have a system of, as hepatologists, as Dharmesh said, we have a lot of time. We always would go there, see the slides. And I mean, that's something which is extremely educative for us. And also it helps the pathologist to also, give a better opinion. And I think both the comments are extremely useful. And
Actually, the pathologist perspective but you keep discussing slides with them after like 100 slides, they would give you better information because you train them, they train you, they understand what you are looking for. And we go there and find out what they're trying to show us. I totally agree with that.
I think with this, we can conclude the session.
Right. Lovely, Vivek. I think this was an extremely educative session of, like we had 3 sessions, and I must tell you that, like hearing Manav would agree with me that very good quality talks, extremely good discussion. And I apologize that we have really crossed a lot of time beyond what was provided to us by the organizers, but they were kind enough to allow us to continue till we are exhausted with our, questions. And all the talks were very good. And I personally would like to thank everybody for being here till the end and contributing to the very educative session. Dr. Manav, if you have any comments, final concluding comments, we're welcome, please. Right. So thank you very much and have a good night to all of you. Thank you so much.
Thank you.
Bye. Stay safe.
On behalf of INASL, I thank INASL, I thank all the chairpersons and speakers for making this session a wonderful session. And also I sincerely thank the course directors, Dr. Sanjeev and Dr. Manav, for preparing such interesting topics. And we had wonderful discussion. And I also thank all the participants for making this a very successful one. Thank you.
Thank you.